Good afternoon, everyone. Today is April 18th, and we are once again convening our Health and Human Services Committee to go through the Department of Health and Human Services proposed FY25 operating budget. We are joined this afternoon by our colleague and friend, Councilmember Jawando, who will be here to, I'm sure, focus on the first item on our agenda, which is a review of the Guaranteed Income NDA. We will also be discussing the Department of Health and Human Services Public Health and Minority Programs. And lastly, we will be going through the DHHS's Children, Youth, and Families operating budget as well. But I begin this morning on sad news. Earlier this week, we learned that longtime advocate and community leader Austin Heyman passed away. Austin Heyman was friends to many of us, mentors to many of us, myself included. Austin served on numerous committees and in numerous capacities for the Department of Health and Human Services and was an incredible champion of intergenerational programming, which led to the establishment of the Interages organization. And his stamp of incredible commitment to our community is everywhere around us. And so, in recognition of Austin's incredible contributions to our county and community, I'd like to ask us for a brief moment of reflection to think about his legacy. Thank you all very much. So, tough transition, but we will move on to the first item, which is a review of the Guaranteed Income Initiative. I'm going to say a few words and then turn it over to my colleague and friend, Councilmember Jawando, who has been my partner along with the entire council in initiating this very important initiative, and give him the opportunity to briefly discuss a memo that he and I wrote to the entire council and provide a little bit of context, and then we will turn it over to Ms. Clemens Johnson to tee up the overall packet. But this was and continues to be one of the initiatives I'm most proud of in my 6 years of terms on the council. As we've all acknowledged, the wealth gap and the disparities that are leading to tremendous challenges in our social safety and infrastructure continue to be a burden and a huge problem. And so there have been similar initiatives in other parts of the country that are more mature than ours that have proven to have very solid outcomes in helping to pull families and individuals out of poverty and helping to enhance overall public health. And I want to give, once again, tremendous credit to the Department of Health and Human Services, who has worked tirelessly with our partners and stakeholders to get us where we are today. The program will be wrapping up in its first term later this fiscal year, in the next fiscal year. But we'll be discussing two tranches of funding today. One, to make sure the program gets over the goal line, and two, to lay the groundwork for a transition to the next phase of the initiative moving forward. And so we know thus far that although we have anecdotal information, we will have more formal, quantifiable information, which is being reviewed. But I know, for example, in conversations that I've had with participants of the program, that one that sticks out is a mom that indicated that there's no way that she could have afforded her children attending a summer camp had it not been for this particular initiative. We know that it has helped with child custody cases. We know that participants have utilized this to attend Montgomery College and advance their education for themselves and of their children. And I'm very proud of where we are thus far, and I look forward to seeing the full review of the program after we complete that part of the process. But I will now yield to Councilmember Jawando to make some opening comments about the initiative as well.
Thank you, Chair Albornoz, and thank you to the HHS committee for allowing me to join. I couldn't agree more. I mean, this is something that I'm very, very proud to have played a role in getting started with Councilmember Albornoz and the HHS team and the Community Foundation and many, many, many others, the Meyer Foundation. And while this is several years in the making, we were doing a lot of things. We were doing it for the first time, you know. And so when you do something for the first time, there's always things you don't know. And a lot of people put in work to make this happen. We had faith and continue to have faith in the program because it's dramatically and positively impacting people's lives. And Councilmember Alvarez mentioned some of the anecdotal stories. There have been, one of the best parts of this has been, there have been kind of quarterly convenings with members that are receiving, the 300 or so families and individuals who are receiving the $800 a month and have been. And every time I go to one of those, you hear these stories of just how it's having a dramatic impact in their lives, from getting out of debt to being able to get on path to home ownership, to one mom, talked about she had her 3 kids and it allowed her to pay the $700 a month minivan lease payment so she could get them to their activities, right? And we talk about positive youth development on HHS and in this council a lot. There's just story on story and positive mental health. Just knowing that you're going to be able to make the bills and feed your kids and get around. It's huge. And I know that I want to thank the Urban Institute, who's our partner on the evaluation. I know that this will bear out in the preliminary and then final report in a demonstrable, not only in every way imaginable, both anecdotal but also objectively in the data. So we're excited about that. Again, want to thank Meyer and the Community Foundation and the entire council who supported it. At that time, 9 members, but last year 11 to keep the funding going. And I have enormous respect, and I just want to do this so I don't forget, to Dr. Mensah, Dr. Nimhard, Ms. Shaw, Ms. Mooney, Ms. Rosarian, and everyone else at DHHS who's helped throughout the process, including its esteemed leader, Dr. Bridgers, who's been along for the ride. I also want to thank the Collaboration Council, led by Elijah Wheeler and Meredith Bowers, who's helped support the participants in a real way, and all of our staffs. Pam Luckett and Councilmember Albanaz's office, formerly my office. She loves this project. She got to work on it with both of us. And Christina Neidlinger in my office, as well as Michelle. And so DHHS, I know we're going to go through the specifics, but I just want to highlight one paragraph from the letter that colleagues received this week, and that will be, I understand, in the packet for the full council, if it's not already in the one for today. We're urging in this second tranche of funding for $100,000 in bridge funding. To support the future of guaranteed income in Montgomery County. Again, the right of people to make dignified choices and choose how to spend their money in a way that supports them and family, and also reduces, as has been shown in other studies, and I think will also show in ours, dependency on other forms of assistance. We say in the letter, the proposed amount would support the preliminary stages of development for future programming, including the hiring of a consultant or agency to gather substantive insights, strategy, operations, supplies, and logistics, stakeholder engagement, and convening, and training. We have sufficient evidence to support proactive steps for future programming while awaiting the full evaluation and its to guide its formation and administration. This is just a small amount of money to show that we need to keep this going. The idea when we started this was that we wanted to obviously help these 300 families, but that it was a pilot in the sense that we wanted to learn from it and use it as a model to maybe change how we provide assistance in the future to other populations. So really appreciate your partnership, Councilmember Alvarez, and the indulgence of the committee to just bring that up today. I think the impact has been clear, and it's not only the right thing to do, it's a smart thing to do. Thank you.
Thank you. I appreciate that. We'll go into more specifics as we go through the packet, but I also want to welcome Councilmember Balcom, who's here joining in the HHS committee as well. Almost have a majority. I will now turn it back over to Ms. Clemens Johnson to tee this up and then walk us through this first item.
Good afternoon, and thank you, Chair Albanos and Councilmember Jawando. We are discussing the Guaranteed Income NDA, the program known as Montgomery County Boost, building our opportunities and strength today. The FY25 recommended budget is $1.23 million. This is a significant reduction to the previous year of $3.2 million. As it is expected, this is the final fiscal year for direct payments to participants in this cohort of the pilot. And I will state that this program started out as a pilot, so we will continue to call it that. The chair and Councilmember Joando went over the specifics of the program, but I'll just highlight that Montgomery County Boost is designed to change the narrative around poverty by providing a regular, unrestricted, guaranteed income supplement to participants. The HHS committee received an update in November of last year, and there was a significant discussion about the report that's coming out, and we'll go on to talk about that a little more within this packet. The Montgomery County cohort consists of 295 participants. I do want to highlight one of the characteristics of the participants is that they have substantially lower income than county residents overall. 79% of the participants reported annual incomes of less than $24,000, compared to 8.6% of county residents earning less than $25,000. So the FY25 recommended budget is detailed on page 3 of your packet. Again, the budget is reduced because the remainder of the participants will be offboarding at the end of FY24 into FY25. I will highlight that the pilot has been a partnership with the Meyer Foundation and the Greater Washington Community Foundation, hoping to support the direct payment pieces of the pilot. There is $61,000 remaining of the funding provided by the Greater Washington Community Foundation, and the Meyer Foundation's funds have been expended. So the current pilot is scheduled to be completed in June of 2025. The governance body for the initiative is exploring future options for the program, and the council members have provided a recommendation for their counterparts to consider to continue the program and present a model to see what that looks like. So overall, the staff recommendation is approval of the budget as presented unless additional funding is required to ensure the evaluator will be available to present to the HHS committee and council. And so that would be at least 3 times, I believe, which would be hopefully May or June of this year, November, and the final report, the next year. So that is the recommendation. Thank you.
Thank you. Yes, so the headline there is we will be formally, as a committee, reviewing the outcomes and the findings that are being conducted by the Urban Institute to make sure that what we believe is true has actually, in fact, been carried out. One thing I'll note, too, in addition to what Councilmember Joando articulated in favor of the second $100,000 tranche, an important element to this program has been the leveraging of funds with our foundation community, and part of the reason why we're supporting the additional $100,000 is to demonstrate to them that we are committed to evaluating this program, and at such time, if it is successful, expanding it. And seeing how we scale that, and that commitment would help make sure that's solidified to our foundation community. So I will pause there and see if Dr. Bridgers, you would like to provide some comments or thoughts, or if you want to defer to your team, that's of course great too.
Sure, absolutely. HHS Chair Albornoz, and good afternoon, Councilmember Lutke, Councilmember Sales, EC Chair Joando, and Councilmember Balcom. This work epitomizes what we do in the community. And I wanted to say that when you unpack the acronym, building our opportunities and strength today in the community, this is the work that we do. This is the interest of the community. I've asked Ms. Hung to join us just to have a conversation, because part of this body of work includes helping those who are transient and homeless. We've had a lot of conversations about all the work these last 2 or 3 work sessions, and I think this is number 3 or 4, but there are some recurrent themes. I've asked our team, our other members, to come to provide you with the granular data of the work, because you've asked those questions, and I promised that during the first session. But this is part of the body of work. I would be remiss if I didn't thank you, Councilmember Albornoz, and you, Councilmember Joando, for help bringing this work to fruition. It's much needed. We can see the fruits of this labor, and we talk about evaluation and evaluating the efficacy or the effectiveness of these programs, which is part of our strategic plans. And I wanted the team to be able to share their thoughts as well. We have a lot of details, granular level details about the data Councilmember Sells, and so we look to respond to that. But this is our work. This epitomizes what we do, helping those in need and supporting our community, and it will continue. Thank you.
Thank you. Did you want to talk a little bit about the program and the operation, just briefly at a high level, what the next few months are going to look like as we transition these families?
Sure, thank you. Good
You
afternoon.
could pull your mic a little bit closer. Thank you.
Good afternoon. Yes. Yes. Thank you. Yes, I just want to give a brief overview of the program so far and the future this year. It will end, as in an offboarding of the current participants. We'll be offboarding by the end of this year. It's a tiered offboarding because it was a tiered onboarding. What we are having in place also is a support network for the offboarded participants for about 6 months with the GI coaches. So it's, we're going to still have that touch and feel with the participants after they've left the program, just in case anything undue has happened to them because of the offboarding. We are doing an offboarding now in person, and we're trying to get a feel of the anxiety and what is going on with the participants, and they seem to be okay, but we all know when 30-day comes, it's completely different than 60 days before or 90 days before. So we're hoping to keep that functionality in place. One of the things that we're working on judiciously right now is the evaluation pieces. So we'll have a preliminary drop of the survey and focus groups in early June. Will be our next iteration, and one of the promises, and it's in the contract for the evaluators, is to present to council and do data walks with the community. So that will be coming forth after the final evaluation and the final report. In terms of the next steps, where I am very grateful for the planning funding, because we are hoping to use the results from the evaluation and some other lessons learned from our administrative pieces to plan what we would like to do for the next iteration. And we can talk about some ideas that we as HHS would like to present. Just from a sustainability standpoint and how you would want to think about framing the next iteration of this. Because of course the next one will not be a pilot is done. So we would need to think about like what the longevity of a program like this look like for the next few years and how we would like to implement it. So that funding would definitely help us structure some formality around that. So I thank you very much for that. Ms. Hung is here to join us because I really want to talk especially about the experiences of the homeless continuum population that was specifically included as a part of the group here. I wanted, we've been collecting their stories, and it's important that the audience understands how impactful, especially to this community of individuals, this program has been. It has been transformative for a couple of people. I know, there's a person who went into rehab because of this. Like when he joined, he was chronic alcoholic. That's the situation we deal with. And to watch people transform like that is really revolutionary. And I just wanted to have Ms. Ong talk about some of those stories with us. I will hear any other specific questions that you have, but I'll turn it over to Ms. Hong.
Thank you, Dr. Nembhard. Ms. Hong? Director Hong.
Great, thank you. So really excited about this program and the impact on the 100 people that were served through the Rapid Rehousing Program and MOCO Boost is really incredible. So the Rapid Rehousing Program is one that is intended for households that are less vulnerable, and they are given rental assistance as well as case management, intensive case management for a year to 2 years, as well as working with employment services so that they would be able to afford their rent and their expenses after the year to 2 years of support. Typically, rapid rehousing has a graduation rate of about 80%. Sometimes households will need to have greater support ongoing. With MOCO Boost, what we saw was the graduation rate was 96.4%. That's a significant increase in the effectiveness of this program as it was augmented with MoCo Boost and the guaranteed income. And the stories that we heard were really incredible. There was a family of 3, and the mom was able to go off of rapid rehousing after 17 months of support. She was afforded 24 months of support, but because of MoCo Boost, she was able to increase her income because of it, and then to pay off debt, and able to pay her own rent and her bills after 17 months. And that says a lot about $800 a month, how that impacts a family. Many of the families who come to us don't have any income when they enter the homeless system. It's about half that do not have income. So yes, our case management has a big job to do, and our employment specialists. Having that $800 a month an additional made such a difference in so many people's lives, so as to increase the graduation rate by 16.4% from the rapid rehousing program. There was another family who they were able to take over all of their bills, both rent and utilities, 3 months ahead of when had the case management and the family had planned to. So that was a huge success, and that family also graduated and has been stably housed for more than 2 years now at this point. And that guaranteed income just solidifies the housing stability that they attained through the rapid rehousing program. We saw a youth who was able to gain employment and pay off $6,000 in back rent, also to then move on to be able to afford all of her rent and utilities on her own. So you can see how MoCo Boost helped people who were in rapid rehousing achieve their goals more effectively and more quickly. So it really made use of the rapid rehousing programs more efficient than it had been without the MoCo Boost. And just more stories of families who were able to move forward and gain stability, afford their rent, utilities, and maintain their housing beyond when the rapid rehousing support ended. So just a real testament to the value of the MoCo Boost and the Guaranteed Income Program on families that really just entered our system experiencing homelessness and left in a better standing than they were because of MoCo Boost.
Thank you. I had a couple of follow-up questions, and then turn it over to colleagues who I assume all have questions as well. And so I appreciate that. And of course, we're going to get the full report from the Urban Institute on the report out soon. And, you know, as we acknowledged during the last committee session, we stubbed our toe coming out of the gates because the provider that we had intended to work with to conduct the evaluation fell through no fault of our own. And so we want to once again acknowledge and thank the Urban Institute for coming in and picking up the slack. But Dr. Nembhard, if you could please remind us what we don't know the outcomes yet, but can you discuss broadly the categories of what they are tracking in terms of what success would look like for this program?
Sure. So they will be looking at financial stability, housing stability, mental health, and I have the list is in my hand. I'm seeing it, but it's around the mental health stability, homeless stability, and there's another one, and I can share it with you afterwards. But there's a list of things that they're going to be reviewing for the participants.
Great.
But I can give you that list from the contract.
Awesome.
I just didn't want to say anything out of turn and then.
No worries. Totally get it. Totally get it. All right. I will now turn it over to colleagues. We'll start with Councilmember Sales, followed by Councilmember Lutke. And then colleagues who are not on the committee, if you have questions, please feel free to share those as well. Councilmember Jawando. Councilmember Sales.
Thank you, Mr. Chair, and thank you for the briefing and updates. Thank you to my colleagues for the letter to help with analyzing all of the accomplishments that this program has experienced. I look forward to the briefing. I know that the Urban Institute is a trusted resource in the community. And so I don't even know if this question's appropriate, but of the participants who started with the program, have any been disqualified because of their new income situation. They're no longer eligible. I think we saw only 5 that were no longer participating, but I know you mentioned, Director Hong, that some were able to change their financial position. So is there an offboarding component to the program?
Only at the end, but not during. So if their
Okay.
situation changed, they would still be supported until the end of the program.
Okay, okay. And let's see. Of the 21%, I believe, of the participants that were unemployed, do we know what their current situation is? Are they still unemployed, or was that number from the start of the program?
That's from the start of the program, and I can provide that data as to the delta currently. I can provide that later. I don't have it right now.
Okay.
But I guess you're asking, of that 21%, how many are now gainfully employed?
Exactly.
I will provide that information.
Okay, thank you. All right, and then in addition, I know the department recommends providing an extended benefit of financial counseling to participants. You know, health and financial literacy are so important to the sustainability of participants as they're in the program. And so, do you have any information about the financial literacy? Is there a completion? Is it ongoing?
I think it was just a preliminary education of, by being in this program, how it would affect your actual finances. But it wasn't a financial literacy in terms of, okay, how do we help you budget? But that was actually one of the pieces that we're actually proposing for any new iteration of this.
Okay.
Right?
Okay.
To have an actual financial counseling as a part of the services within the program. But during the onboarding, we did initial financial counseling as how this change will affect your current situation.
Okay. And then I see that, I believe it's Circle 15. It says HHS is currently working with the Federal Reserve Bank of Atlanta to secure access to their career ladder identifier and a financial forecaster, the CLIF program and planner. Is that underway? Are we still waiting to be connected? What's the timeline?
It is still underway. I think the last time we checked, it was almost fully done for us to kind of start using. But it's one of the things that we are hoping to kind of leverage during the offboarding period with the participants. But I think it's almost done the last time we checked. It was in draft a couple months ago. But they've evolved the site a lot from all the learnings, because they are also associated with other GI pilots, and they've been evolving the site to make it more user-friendly for different jurisdictions.
Okay, if you can get us an update on the progress and implementation. And then you said that how many focus groups have been held since the program's inception?
The focus groups haven't started yet. We've done the surveys. We're now reaching out for participants for the focus groups.
Oh, okay.
Yes.
Okay.
That's the reason why the next deliverable is kind of the end of May, because right now we're gathering the focus groups.
Okay.
But we haven't done the actual event yet.
Okay, as long as we have that information once the Urban Institute report comes out.
Yes,
Thank you.
Thank you. Councilmember Lukey.
Thank you. So I know, as in the materials we have, and also you've already discussed here today, that there's the tiered offboarding because it matches the tiered onboarding that the participants underwent. And I note that in other programs, they did a taper off of the amount of the payments as they went down. Could you speak to why we chose not to do that in this particular case, or what you might have gleaned from other jurisdictions that have done that in their guaranteed income programs?
I don't think it was an initial thought for us. And I think once the program started without that perspective, we couldn't quite implement it now.
Right.
But from the other jurisdiction, it it didn't really make a difference in terms of lessening the blow, because our program also was the same time frame. So the ones that were tiered down, they weren't longer than our program. So
some of them were shorter.
Yes,
like some of them were only like, there was one, it was only supposed to be a year, but then because of different pandemic considerations, they extended it for another 5 months but that one did have that step down. And I don't know the answer to it. I just, I'm sort of curious from a comparative analysis perspective, what can be gleaned from that over time, as you discussed, with folks knowing that these things are coming up, and it does have a, a psychological effect of this is going to come to an end. That whether that kind of approach, if examined in the context of other studies, could inform what might happen in the future here and help to discern whether that's a good practice or not the right practice for what happens in Montgomery County. And then, in looking at there's the total cohort that you have, started with 300, 5 dropped out. But within that 295 that remained, there's actually kind of 2 different cohorts of people, right? Because there's this, I call one, or I think of one as the CEF cohort, and the other as the not CEF cohort. And I wondered, were you tracking or doing any analysis of a control group at the same time? Because I have seen that done in other of these programs, and so we can say, and thank you, Director Hong, for expressing the increase in the rapid rehousing stability and completion piece, which is great. Like, that's what you want to see. That's the outcome you want to see. But it would also be good to say this is what happens without that for this population. And again, they have very distinct characteristics, and so I don't know if for the CEF cohort, if you will, if they were all those for whom rapid rehousing was the appropriate program, or were other individuals who were coming in through the CEF door, if you will, in this boost program, but not appropriate candidates for rapid rehousing, because those are different criteria.
So one of the things that Urban is going to look at, they're going to do a comparison group for both cohorts, the CEF cohort and the main cohort, and they'll be looking at the influence of course, the pilot with or without. Mm-hmm. There's also elements in the main cohort that might show up for the CEF cohort, and they'll also be looking at that, because housing stability, the main cohort of individuals, right, they didn't come in under housing stability framework.
But it was still an issue.
But it was still an issue.
Right.
So that would also be assessed. So all of that will be looked at. And they are going to do a comparison group for both cohorts.
And I think, and overall, especially now's the time of year when it's always top of mind for us, because we're looking at each of the programs all together because we're talking about budgetary funding. But really in the grand scheme of like functionality, not only assessing this, but taking a look at each of the other different pathways or portals to assistance that we have, and seeing what works on its own, what works in combination with something else, how do they need to work together, because we may have disparate incomes. Yes, we do have disparate incomes, but we may have impacts. Yeah, we may have disparate impacts based on what the initial assessed need is and whether it needs to be coupled with other programs in order to reach the level of success and sustainability. And for me, and this is just like analytically how I'm thinking of it, I'd want to know and see the control groups versus the participants in Boost. Where are you in terms of stability 12, 18, and 24 months out from participation? Meaning, how sticky is this? How sticky was the assistance? How much did that, and again, knowing full well that it is true that everything you do that gives you individual choice and volition and agency in your own self-determination is critically important. But you did mention there isn't that financial counseling at the end, and so that may be relevant in the, hey, that was a missed opportunity in this group. Maybe we should make sure we're doing that so that as you're off-boarded, there's a period of time where you have that. and there might be some assessment needed to determine if folks are ready, it's time for their offboarding based on the scope of the program, but they may need assistance, like a rep payee might be indicated based on other circumstances for that individual. So just sort of like things I'm thinking about. And I wasn't sure if any of the participants had as a sole source of income either when they entered Boost or upon application while involved with Boost, whether their sole source of income was SSDI.
I think maybe one participant.
Okay.
It wasn't many, but I can get that back for you. But it really wasn't many.
Okay.
It was about one participant.
Just knowing that too can, in and of itself, be a troublesome thing for someone to be living and dealing with, and they may not have the same ability to work or do things that but they still need a roof over their head, and they need the ability to still engage in self-determination. So that would be something I'd love to know more about. And sorry, I wrote all kinds of doodles on my page. Thank you for mentioning that regardless of whether someone plateaued in what you would consider stability midway or partway or whatever through this program, that you get to continue to the end, because it's important that each participant has the same length of participation in order to then you would be able to know if you've indicated based on a particular participant's stability, maybe it was 18 months in, they reached that spot, but they're going to be terming off soon. Then if you're doing the evaluation at the 12, 18, 24-month period later, you may see that those who gained stability earlier on had better longer-term outcomes, for example. So that's something that I'd be interested in seeing in the final research, final analysis that the Urban Institute does. And I want to thank my colleagues for putting in their letter the Guaranteed Income Research project at the University of Pennsylvania, which I know I shared with both of you. I'm a very proud Penn alum, and I'm very proud of the research work that they do. But I think we need to look at this along with the other services we provide that fall under the DHHS umbrella and figure out the best use of resources, the easiest access, because again, hurdles to access hurt us all, and the best economic resource for how we are maximizing the funding to deliver the services, to deliver the stability, because that at the end of the day is the goal, and to make sure we're doing that in the proper fashion. So thank you.
Thank you. Councilmember Jawando.
Thank you also, and really appreciate the discussion and the questions. Really excited to hear about the, that you could say in public about the control groups and just the being able to look at that. That's going to be really helpful. We're a little busy in May, so it probably makes sense to come back in June. We were just talking about that, but I'll defer to the chair and to council staff, but that'll hopefully allow enough time to get that initial report. One of the reasons I just really am so proud of this, but also just really excited to keep it going, because the whole goal here is how do we analyze this and use it to inform how we support people in a dignified way where they can make their own decisions. I quoted this when we introduced it a couple of years ago, but this trend has continued and gotten worse, unfortunately. The Fed does an economic well-being survey every year, and last year 4 in 10 Americans couldn't find $400 if they were pressed of cash. They would have to go to a credit card or take a loan or borrow it from someone in their network. And so I think we have to just remember that context, that we're doing this in the context of really difficult economic circumstances for many, many Americans, right? Even gainfully employed, right? We have under a 2% unemployment rate, but obviously a significant underemployment rate, right? I was just at a conference, Councilmember Albanaz and I and Councilmember Mank were at a conference at USG talking about how we improve the connectivity and upskilling of folks in the workforce to get them enough money to meet their needs. We know how many people are housing burdened in this county. So there's there's a lot of factors that factor into this, but to hear that some of those initial stories is really heartening. And I think it connects to the stickiness that Councilmember Lukey is talking about, in that I think we have to just redefine and just really think more broadly about what success looks like in this context, because it's hard for so many people, and you're going to have ups and downs, and so, but I do think it makes sense over time to look back. And as you're planning, hopefully we can get this money for you to continue the planning with the consultant. Looking back at key points in time going forward, I think will be helpful for us to know, how we can best provide that layering of support. My colleagues have gotten used to me talking about this Swiss cheese approach, right? We're covering different holes. This is not going to, bring financial freedom to everybody, but it does in some sense that you can make your own choices. It takes off a little bit of that pressure. That's why we called it, as you remember, Dr. Nimhart, that's why we named it MoCo Boost, because it's a boost. It's a little bit of a, leg up in a really tough world. And I'm excited to see the information, but I just want to make sure that we're keeping that in context. And I did want to ask you, Ms. Hong, who's about so the 96.4% was a 16.4% increase in rapid. Just explain that again, what that means for the layperson.
Sure. So rapid rehousing provides the rental assistance to households as well as the intensive supportive services for either 12 months or 24 months, depending on whether it's locally funded or federally funded. And the goal is, of course, for that household to graduate and to be able to cover their rent and their expenses so that they won't need that supportive service and rental assistance any longer. So it's in Montgomery County, it's very successfully applied, I would say, because we assess that intervention specifically for households that are less vulnerable, who are able to increase their earned income. Still, we see that it's about 80% who are able to go off the supportive services and the subsidy and maintain their housing independently. That's a pretty high rate nationally, but the fact that 96.4 were able to do it who had MoCo Boost says a lot. We know that oftentimes when folks are able to increase their earned income, they still can't afford rent in Montgomery County. This is the problem with housing affordability in our county and many jurisdictions across the country. So for me, it's very encouraging that with that boost, so many more were able to graduate and pay their expenses, and did. So that, that to me is part of the value of the guaranteed income, that there are many households that will continue to struggle to afford housing in our county, even though they are employed and they have everything working in their favor. They're able-bodied, they're able to care for their children and be connected to resources. They still will struggle because their income level will be too low. So to me, it justifies continual funding of the MoCo Boost and Guaranteed Income program in our county, because the affordability is not there, and we know that housing is such a major determinant of health across the board. And so just to see these families and individuals thriving and doing so much better, going off of rapid rehousing ahead of schedule, paying off debt ahead of schedule, is a huge success. It's a testament to the success of MoCo Boost.
Yeah, I appreciate that. Thank you for just elaborating. And I think it's hard to overstate the this is one indicator, which is a key indicator, like housing stability and being able to get off and support your bills. But the cascading effect that has on student mobility, on the mental health of those families, on even food security. I just think again we will learn more, but I'm excited about that. Thank you, I appreciate it. Thank you, Councilmember Alderman.
Thank you. Great questions, good points. We'll have more information when we dive into the outcomes. I'll just note one final thing before we get to the 2 votes for the 2 tranches. One is that we were very cautious throughout this entire program to not unintentionally then disqualify participants from participating in other federally funded or state funded programs. And that was not easy to do. And so and as Councilmember Jawando stated, and I think everybody recognizes, This was never intended to supplement, it was intended to enhance. And so to Councilmember Lutke and Councilmember Sales's point, as we conduct the evaluation, there's a lot of different permeations of that evaluation that will be important. The one most specifically is the program before us, but its connection to other programs and maybe a strong model for how we evaluate other programs is something that will be good that comes out of this. So with that, colleagues, we have two levels before us. I'll start with what is in the packet, and that is the $1,229,850 to get the program to the finish line as had been originally intended. Without objection, we will support that. And the second is the $100,000 tranche to put a placeholder for some initial planning funding, because it's likely that the full amount yet to be determined based on the outcome of the evaluation would not come until FY26, but there would need to be some prep work done to get us there. So that's the purpose of the $100,000. Colleagues, do we support the $100,000? And it's okay if we don't.
I want to put it in a separate
Yeah, it is a second tranche. This is a second tranche.
Yeah. And just to speak to that, only because I feel like if you're planning for something that hasn't been fully evaluated
Yes,
yet, you're putting the cart before the horse. So it's not that I don't think the work is going to have to happen at some point. It's when it's going to happen. And as you just noted, we wouldn't necessarily be ready for that till FY26. So
Okay.
That's my preference.
Gotcha. And I do support the $100,000. Councilmember Sales?
I support it.
Okay, so it's 2-1 in favor of the $100,000 planning fund. Great. Thank you all very much. We now move on to the next item. I want to make sure I got that right, Ms. Clemens-Johnson. Did I miss anything?
We're all set.
Okay, great. So we move on to the next item on the agenda, which is discussing our public health and minority programs. Thank you. Yeah.
I know it's a thing, it's a question of when.
All right, Ms. Clemens-Johnson, I'll turn it back over to you.
Thank you. Thank you, Chair. All right, we make sure we had all our folks at the table. We are discussing the FY25 budget, recommended budget for public health services. The recommended budget is $118 million for FY25, the difference of $13 million or 13% for this fiscal year. There is a total of 617 FTEs recommended, a difference of 36 FTEs from last year. On page 2 of your packet, there is a comparison of the budgets for the programmatic budgets, and also a comparison of the FTEs. If we go down to the vacancies, there are 42 vacancies within public health currently. 16 of the currently vacant positions are grant state funded. Most of the vacant positions in the general funds are the new positions in dental services and school health services that were supported in FY24. Overall, 5 of the positions have been vacant longer than 1 year. On your next page, you'll find an update on 3 of the programs from last year. I won't get into a lot of detail about them, but first was the COVID testing and vaccinations. There is a recommendation that we'll talk about later in the budget as a follow-up to the continued testing and wastewater surveillance that the DHHS would like to continue to engage in. The last update is on the mobile health clinic. The HHS committee discussed the mobile health clinic in November. The bus still isn't here yet, as I understand that it will be expected production is complete of August 2024. I think it's the longest we've waited for a bus. And so we are looking forward to that getting started. But regardless, the mobile health clinic team has started their work providing services in December 2023, helping over 335 patients, and approximately 15% of them require case management and coordination services. So the staff is off and running, but we'll get the bus together soon. So the presented on page 5 of your packet, and I'm sorry for the lack of page numbers. That was an oversight, but hopefully you're numbering as we go along. So we have the chart of new and enhanced programs. As you see, a number of the recommendations for funding of FY25 are enhancements or new programs that are suggested for the year. There are potential reductions as staff was instructed to identify, and we'll, as we go through the packet, we'll identify those. The first item we'll start with is the Local Health Disparities Grant, $548,000 and 0 FTEs. This grant is to address the impact of COVID-19 related racial and ethnic disparities, chronic disease prevention, disease management, and social determinants of health, specifically on transportation barriers. Council staff recommends approval. The response says that this focus will be on transportation barriers to care, and the consultant will design a health equity plan. And so, as this is a grant, we won't show this on the new and enhanced program list, and it is before you for your consideration.
It's a grant, so, but any questions or comments on this one, colleagues? Nope, without objection.
Thank you. Next is a requested enhancement for operating support for WUMCO Health, $232,000 and 0 FTEs. This is new funding. WUMCO aims to help coordinate a collaboration of community partners to provide access to primary health care, comprehensive dental care, and behavioral health interventions, along with other supportive health services. WUMCO's service area consists of 5 zip codes that include Poolsville, Barnesville, Bealsville, Boyds, and Dickerson. It is ongoing funding. So the council staff recommends approval. We did receive testimony that the Up-County area served by WUMCO Health has only 2 primary care physicians that serve about 12,000 people, and it is difficult for many more people to give services that are at least like 10 miles away. The executive has proposed this as ongoing, and if the committee approves this item, it will be included in the new and enhanced programs list.
Thank you. First, want to acknowledge and thank our friends at WUMCO, who've done an outstanding job. And I love community-driven programs, initiatives, activities. They're wonderful and they're impactful for so many reasons. I now want to yield to our colleague and friend, Councilmember Balcom, who sent a memo regarding this particular line item.
Thank you. Thank everyone here. Thank you for having me, and thank you for the team. So during last year's budget, we really started focusing on a rural health initiative, some type of focus to look at the unique needs of our rural community. Not only is it the lack of primary care providers, but the transportation issues that they face, a lack of transportation. And this year, I'm so pleased to see funding proposed for WUMCO, which will allow much more comprehensive safety net for our residents. And WUMCO's been in our community for over 50 years, providing trusted service to our residents. And I want to thank the entire public health team and, of course, Dr. Bridgers for really taking the time to understand this community and understand the needs of the community. And I also wanted to note that we have the proposed Western Montgomery Community Center that will include clinic space. It will be a unique community center in Montgomery County. And this proposed funding will allow an expansion of health care way before that building is built. And so I appreciate you having me, and I am asking for support for this proposal. Thank you.
Thank you. I'll yield to colleagues. Any comments or questions? Councilmember Lutke?
I support. There you go.
All right.
It's easy.
So I think without objection on this one. Great. Thank you very much, Councilmember Balcom.
Okay, next item is the program area communicable disease and epidemiology. We just wanted to highlight the multi-program adjustment, which includes 4 FTEs, which DHHS says are the conversion of a broker position, changes in charges to grants, and a new PAA in the TB clinic. So this infrastructure position will be discussed along with the other ones that we discussed a few days ago on April 29th, not May 29th. May 29th hopefully will be completed. The next program area is community health services. The first recommendation is replacing federal funding to ensure prenatal program engagement with vulnerable populations. This recommendation is $48,000. We know last year the state opened the Medicaid program to begin seeing women who are residents here regardless of their citizenship status. And so that replaced our maternity partnership program, but the services at the Medicaid level do not match that we provided with MPP. So DHHS still saw the need to provide the case management services to help those women navigate through their pregnancy, and also providing home visiting support for their families as well. So staff recommends approval of this item.
Councilmember Sales?
Yeah, I just had a quick question. If it's not additional employees, what exactly is the $48,000 being used for?
I'm happy to answer that, and also would ask our Senior Administrator, Rebecca Smith, to come up as well. So these additional funds are going to be used to cover, as was mentioned, the enhancements that are covered beyond Medicaid, right? So transportation, gift cards, childcare, pack and plays for safe sleep, things that aren't currently covered through the Medicaid benefit, but are services that we know are critical to ensuring that our infants and our moms have a safe start to this next chapter in their lives. Becky, I'll turn it over to you to add anything else.
And the only other thing to add is that in the past, when we had our maternity partnership program, the participants were kind of indebted to us we were providing their prenatal care. The county was. We were providing the funds for their prenatal care. And with that prenatal care came a home visitor that would come to your house, a nurse or a community health worker. With Medicaid, there is no strings attached. You don't. The nurse is something very separate. And this is having some of these funds for incentive items can encourage folks to participate in our programs. So
good. No, with the maternal health rates, this is a good program. Fully support. Thank you.
Thank you. On a lighter note, you used to have an advanced degree to put together those pack and plays. Now it's like one button, so it's really remarkable. That's great. So with that, I yield back to you, Ms. Clemens-Johnson.
Okay, thank you.
Without objection.
Okay. Just wanted to note the technical adjustment within the same program for a contractual lactation specialist conversion to merit staff. So DHS let us know that they were unable to hire a contract lactation specialist, and they used those funds to train some of their staff to actually get a certified as a lactation specialist. So this is to transfer the contract position into a merit position. Council staff recommends approval.
Without objection.
Okay. And the next section is dental services. I believe we're going to tee this up and receive a presentation from DHHS.
Great. Mm-hmm. Mm-hmm.
Good afternoon.
Good afternoon. Good afternoon. My name is Dr. Tricia Boyce. I'm the dental director for Montgomery County Public Health Services.
and Dr. Christopher Rogers, Policy and Strategy Officer for Public Health Services. We're going to tag team the presentation for you all today. Next slide, please. As with the entire healthcare industry across the care continuum, dental patients, the number of patients served took a dip during COVID. However, we are beginning to see an increase in the number of patients that we see across our dental clinics, specifically with our children, something similar that we are seeing in our Care for Kids program. We do anticipate exceeding the number of children seen in our dental clinics in FY25. In fact, as of March 2024, we've already seen 2,506 children. You do see a decrease in maternity, and that's as a result of the Healthy Babies Equity Act going into effect and the Maternity Partnership Program. Now, next slide, please. So specifically as it pertains to children, I'll highlight it coincides again with our increased enrollment in Care for Kids. And we do expect to exceed the number of FY23 patients in FY24. We have already seen, as of March, 4,286 children seen in our dental clinics. Next slide, please. A year or so ago, we committed ourselves to being a resource for Medicaid patients in our county. The positions that the county executive have requested in FY25 will continue to enable us to see more Medicaid patients and to realize revenue or reimbursement for the county government. We do see ourselves, the county dental, as filling the gap in the low number of Medicaid patients. Low number of Medicaid providers in the county, and so we want to continue to be a resource, and that FY25 recommendation will enable us to do that. Next slide, please. As it pertains to appointment wait times, I'll just highlight a couple reasons why we have these number of patients on a wait list. One is the general dentists at our Metro Court location are experiencing provider staffing shortages in that particular area. We also are experiencing some infrastructure and facility challenges in our Metro Court location. We have a dental chair that's down, and so this is mainly impacting our Montgomery Cares patients in our Metro Court location who are in need of seeing a general dentist. In addition to that, we are making improvements as it pertains to oral surgery because we've had one oral surgeon volunteer, so that has enabled us to reduce that wait list over the past couple months. Next slide, please. The community health needs assessment, we had a oral health capacity and demand environmental scanning, so just want to highlight one of the findings on this particular slide, which is less than 5% of dental providers who responded to the survey stated that they accept Maryland Healthy Spouse Medicaid for adult and children. So this is consistent with the numbers that we see across the state and that come to us from Healthy Smiles, as well as the dental collaborative that we had early today. We heard about the challenges as well. Next slide, please.
This slide focuses on some of the policies that have influenced the patients that are coming into our dental clinics. One, of course, is Montgomery County being one of the top 10 landing sites for migrant asylum children, and we've seen that increase significantly from 2019 to present. Also, with the adult Medicaid expansion that went into effect in January of 2023, we saw some of our existing patients convert into being eligible for this service, but that program, while it was wonderful, it did come with some shortfalls in what it covered. So that was one of the influencing policies for our program, and then also, of course, the Healthy Babies Equity Act that went into effect in July. That's why, as Dr. Rogers mentioned, we've seen a dip in the amount of pregnant women that we're seeing, but there is a shortfall with that program. It only covers 4 months postpartum and not the full year as other pregnant women. I'll go to the next slide, please. Some of the challenges for the dental program have been us moving from accepting only uninsured residents to starting to accept those with Medicaid. Our capacity, of course, issues are there. And then there are compliance requirements that come along with that. I'll go into that a little bit more later. The other thing that's happened, kind of as I've mentioned before, is that we found the need for our adults and seniors to be eligible for both programs because of the shortfalls of the adult Medicaid program. Our seniors who have Medicaid, they still need dentures. That's not covered. And again, our pregnant women, the Medicaid coverage ends at 4 months postpartum, but they definitely have needed additional services. The other challenge that we've seen is recruitment of dental providers. As of present, I'm the only merit staff. All of our dentists, they're contractual. They're under our oral health solicitation. Our oral surgeons have been they're volunteer, and volunteering half a day. It's created long wait lists. There's been a lack of consistent appointment availability for our patients. Part-time contractual staff, a lot of them have other practices outside, so their priorities are not always with us, so it's challenging. The other thing is bringing on our dentists under the current structure of an oral health solicitation. They're only paid once a month. They have to provide their own malpractice. Can make them gun shy to treat or even to join to provide services. Some of the other challenges, next slide, sorry. Some of the other challenges we're experiencing is to be in compliant with the state, we need to move from a flat fee structure to a sliding fee structure. There's infrastructure challenges with that, even just software support, or even we want to make sure that we don't have patients who are suffering with this transition. We want to make sure there's financial assistance within our program to help. What we've also found is that when we refer to other programs, the patients are subject to that program's, and when I say other programs, community partners, they're subject to that community partners fee structure, and our fee structure is much more accommodating right now. When they go to these other organizations, they can't afford what the other places are charging. As Dr. Rogers mentioned, we have a lot of outdated equipment, almost 20 years old. There's things I am constantly having to replace. Also, our Colesville clinic has been closed since August of 2019. That's left a hole in the East County region where there is a lot of demand for services. Of course, next slide, there's administrative staffing support as your program grows. You definitely need more administrative staff. And then just in general, the meeting the population's demand. We have an increasing number of Medicaid patients turning to the county because they cannot afford non-covered services that are being presented to them in the private practices that are Medicaid providers. I think that goes along with the reimbursement structure right now with Medicaid. It's pretty low. So these are some of the challenges. And also an increasing number of pediatric care for kids patients that need specialty work, finding providers to even participate with that for root canals, crowns, and even OR services has been a challenge.
So in partnership with our community partners, we've developed a multi-pronged strategy to expand dental care access for our community. What we want to focus on at the center of all that we do is oral health value-based care, which we'll touch on the next slide, and we'll touch on a few other these points on subsequent slides. But let me just highlight a couple of things here that we've committed ourselves to reducing our wait list for FY24. So all of the patients who have been on the wait list prior to April, we've committed ourselves to wanting to eliminate that wait list by the end of this fiscal year. The FY25 positions that the county executive has recommended in his budget will enable us to realize these strategies on your slide that you see here. Mobile dentistry has come online. We are providing oral health screenings in the community, and we are referring patients back to our physical dental clinics, and we continue to look forward to expanding that service in Poolsville and other parts of the county. The last thing I'll say is that the dental collaborative that we've stood up with the community really focuses on a number of these approaches. For example, how do we increase referrals to community dental providers? We don't have to do everything ourselves in county dental clinics. We know we have capable dental providers in the community, both academic, safety net, and private. And so we want to make sure that they are seeing our patients and that we are referring them and that we are reimbursing them in an oral health value-based care capacity. Next slide, please. Just briefly, this is a visualization of what it means when we say oral health value-based care. Couple things that I'll focus on, really things that were emphasized in the third dental collaborative meeting early this morning, is really focusing on that minimally invasive techniques for our patients. Also really focus on that medical dental integration. And so as we treat patients for oral health care, we also want to address the chronic diseases such as diabetes, those things that increase someone's risk for experiencing caries and those types of oral health conditions. Also, we want to make sure that we are addressing social determinants of health, and so that really speaks to that personalized, specific approach for our patients that we have seen. And we want to integrate these principles into our contracts that we are setting up with our dental providers as we seek to refer them. Hence the dental learning collaborative, so that we can all come to an agreement for what this system should look like and will look like as we look to increase access to care. Next slide, please.
We found the need to increase providers in the areas of dental hygienists. Hygienists are just such a cornerstone of the dental practice, and especially in the public health space, we want to make sure they're working at their top of their license. There's so much that they can do outside of just traditional providing cleanings. In the public health space, they can actually place temporary restorations. They can place decay arresting, minimally invasive care materials. There's a lot that they can do for our population that we really want to make sure we're getting them out there in not just our clinics, but also on the mobile, in our schools, which they're already doing, actually. But we see that as a huge win for us. Also, this population needs more frequent recall care, period, for cleanings, which is something, because of the amount of hygienists we have right now, we have not been able to do for a long time. And so that's an area that we really feel needs to be strengthened. We've also asked for a general dentist. We would like to provide more just general dental appointments, and somebody who's there full time, who's committed to the program. And of the oral surgeon, we see the need for that too. We would like to, because what we're also seeing is a lot of referrals from the community for extractions, saying you go to your local health department, they'll do it. Well, we're already really strapped and we don't have that. The other thing is one of our goals for an oral surgeon would be to enhance our practice and create an area for sedation. That's a huge item that we refer out a lot for especially our Care for Kids patients, of course, and then also some administrative staff is something we're asking for too. Next slide. Oh, thank you. Sorry. So we started in our schools. We started in March. I did want to say that when we first brought this program to you guys pre-COVID, we started out with 16 community schools. When the MOA, Memorandum of Understanding, was finally signed in November, it was 26. I've recently been told it's 34 community schools. So the demand is there, and in the schools are ecstatic. Our patients, the parents are happy. One of the things that we want to do, though, is expand the program so that it's a full scope of services can be offered in conjunction with the mobile health clinic. One of the other initiatives that we have started, actually we're in the final signature stage, at least with University of Maryland, is providing specialized dental services at their location for those patients who need things such as root canals, crowns, dentures at a severely reduced cost. That is something that is severely needed, but we're also working with the University of Maryland to try and incorporate some of our value-based care elements, such as minimally invasive care dentistry, like Dr. Rogers mentioned, more incorporating on Carrie's risk management and managing of patients with chronic diseases and pregnant women. I'd like to end with a case that came to us just over a month ago. I received an email from a school nurse asking for resources to help an 8-year-old child with severe tooth pain that had been crying in class all day. The child's parents had been told that a root canal was needed on a front permanent tooth. The nurse and parents were having difficulty finding a dentist or specialist willing to do a root canal on a child that young. This child did not attend a community school, and this child had Medicaid. When they did not find a root canal specialist who participated in Medicaid, the parents were told that there would be an additional $500, or I'm sorry, when they did find, let me rephrase that, when they did find a root canal specialist who participated in Medicaid, the parents were told by that doctor that an additional $500 would be charged for services not covered by Medicaid, and the parents could not afford it. I also had difficulty finding a private practice dentist or any of my colleagues willing to do root canal on someone that young. Although the county dental clinics don't currently see children with Medicaid, we determined this was a serious situation, and we brought the child in. The child was taken out of pain, root canal was started. This child, though, because of this case, will still need to see a specialist, and we still have to find that for them. But why is all this important? If it is this costly and difficult for a Medicaid child to receive specialty dental services, imagine how difficult it is for an uninsured child or even an uninsured adult or an adult with Medicaid to receive specialty dental services. This case highlights the need for a collaborative network of general and specialty dentists to provide general and specialty dental services for the uninsured and Medicaid patients. There is also need for mobile services to bring dental services to the communities of uninsured and Medicaid patients, such as schools, churches, community centers. Eliminating barriers to dental care such as transportation, but at the same time connecting these patients to a brick and mortar dental home. The dental issues of the county are a challenge and reflect problems experienced nationwide. There's no easy fix, and it's going to take some time, but I do believe that with us all working together, we are moving in the right direction. Thank you.
All right, thank you both. I have a couple questions, comments. First, thank you for these efforts. Dr. Rogers, Dr. Bryce, I know you've been working very hard on this issue, and I know there's this collaborative approach to enhancing the overall system. What's before us today is increasing capacity within HHS, which you've made a very viable case for just in general that will help contribute to that system. We're waiting for this mobile medical vehicle, which we know will have a large impact, and we look forward to that. I know we've had some conversations regarding USG and that being one of a number of assets that we have before us. We've toured together some clinics such as the Mary Center. Could you just expand a little bit on the how we envision bringing in our providers and outside organizations and agencies? How does HHS envision bringing them in to enhance that system to be able to expand our reach even further.
Yes, thank you for that question. We are committed to expanding access with our community partners. USG, we receive proposals from other community safety net providers that would like to partner with the county. The Dental Collaborative is really the place where we are talking as a community about how best to engage with the stakeholders. And so some of the things that we are looking to do is develop some accompanying processes and referral protocols so that when a patient, for example, uninsured patient, presents to one of the county dental clinics and we don't have the capacity to see that patient, or if we do have the capacity to see those patients, we're able to refer that patient out to, for example, USG, Muslim Community Center, Catholic Charities, Murray Center, CCI, etc., in order to provide services for that patient. Both their routine preventive care as well as any ongoing specialty care services. So those providers will become the patient's dental home to provide all those services. And then we would also really focus on setting up those contractual relationships in an oral health value-based care mechanism where we are also incentivizing those providers to conduct some of those minimally invasive treatment services, make sure we bring the patients in for their routine biannual dental exams, and provide them with reimbursement accordingly. We do have existing partnerships with USG, for example. Dr. Boyce referenced one. I don't know if you want to reference one more. So.
We also have a MOU with the School of Dental Hygiene at USG so that we can work together through the Dental Connections program and sending more patients over there. So hopefully, we're hoping that will get completed any day now so that we can start that process. We are eager to start referring patients over there.
That makes a lot of sense, and I appreciate that, Dr. Boyce. I guess there is an expectation at some point, once the collaborative has, I know they've convened, I know they continue to meet, but that we will come back to this overall system approach, because we need to meet these organizations part of the way in order for them to be able to meet their capacity, because we're able to uniquely leverage, because we haven't discussed this yet, but some of those organizations are in a better position to provide culturally competent care that sometimes the county can't provide on its own. And we know that language access and other barriers is also significant. And we need to spread ourselves out to every corner of the county, and we're not going to be able to do that on our own. So I certainly concur and will support the recommendation, but do still expect that there will be a broader systemic recommendation by the collaborative that will have a dollar figure associated with it, that will include probably some operating and maybe some capital dollars too. But we've all made commitments, and I want to thank our colleagues and friends in Action in Montgomery and other advocacy organizations who've really taken the mantle on this issue and brought it to our attention. Councilmember Lutke and Councilmember Sales.
Thank you, and I think Dr. Rogers read my mind when he mentioned the folks in East County and going to the Muslim Community Center, and I know, they're very proud of the dental clinic that they offer there in addition to their other care services, and they've been a very good community partner in this work. One question I had was about the University of Maryland School of Dentistry services at Shady Grove and capacity. So I know, and we've talked before about the transportation issues, which are vast. But it's my understanding that the clinic there has a lot more capacity, that it is being underutilized in the grand scheme of things, not necessarily by you, but I'm saying overall that they have more capacity. And so I'm wondering what could be done if we're needing to get people to that site, if they have availability in terms of transportation being that barrier.
Yes, thank you for that question. As you are aware, OLO conducted the transportation barriers to medical appointments report, and on behalf of HHS, I led up the efforts to bring together community partners to put forward some recommendations based on the findings of that report. I know that the executive office is looking at those recommendations now. So it would require some perhaps new funding to address transportation barriers. Right now, the Community Population Health Division and Public Health Services, we leverage existing MDH funding through that local health disparities grant that you heard about earlier, in order to provide transportation assistance across our portfolio of community population health programs, which includes dentals. We anticipate hopefully receiving some funding in FY25, and we can continue to provide those services. It will, and USG agrees with this, it will take some new funding in order to fill some of those chairs in USG, hence the proposal that they provided to the county. However, as Dr. Boyd shared, we are committed to seeing how we can leverage existing funding to expand capacity currently with USG, for example, through the Dental Connections program, which I know Councilmember Albernos was instrumental in, and the Montgomery Kids Advisory Board a couple fiscal years ago. And so we are looking for innovative ways to do that right now, because we know it can't wait. And so I believe you'll be seeing some movement on that over the next several weeks as we finalize the MOA.
Okay, great. My dental appointment's tomorrow morning, by the way. So, but you know, I used to go to the clinic in Baltimore at the School of Dentistry. That was one of my care sites way back when. And I did note that there were a lot of seniors who came for services there. But of course, there's more public transit available in and around Baltimore City that helps facilitate people getting there. And, you know, I know Councilmember Balcom's not here anymore, but on behalf of her, even pretend she's in this chair. And in my district, that's not the case, right? Our districts are the least public transit friendly spots in Montgomery County. And so, particularly for our senior populations there who may need access to care, whether it's dental care or it's regular health care checkups, we know that is an ongoing issue, and I know that's documented in the report, in the slides where it shows the by region and by zip code the different disparities that are occurring and why. And I noticed that my zip code itself was dead last on one of those slides. So, yeah, thank you.
Thank you. Councilmember Sales.
So I just had a question about the status of the MOU for the work with USG and how that impacts the budget request for the 7 staff members.
I'll let Dr. Boyd speak to the status of the MOA, but the 7 positions does not impact the MOA and the progress that we will make with USG.
The MOA is actually sitting with USG right now, so they're reviewing it. It's already gone through Office County Attorney's Office, so we're really at the final stages, and so we're hoping that this should be completed soon. So that's really where we are.
Okay. Yeah. Okay. Because like Councilmember Lukey mentioned, I was talking with Dr. Rogers about the University of Maryland Baltimore Clinic, the Howard School of Dentistry Clinic, and we actually received emails from constituents who are practicing dentists who wanted to know why we were underutilizing the USG clinic, and so I'm glad to see that progress is being made, and we'll get some updates soon about what sort of capacity they'll have and how we'll be able to facilitate that transition. So how long have they had this MOA?
I want to say it's been a little over a year. There was a pause because of a change in leadership over there, and we've been pushing for it because we really wanted to start sending, but I think it was just a change in leadership at the actual USG dental campus that put a pause on it, and that pause was around November, December, but everything picked back up in January. So we've done our part, so we're hoping to get it going. Yeah.
So when was the last time we made contact to find out what the timeline for a response is?
I believe I contacted them, I think it was last week, to see some updates, and they're reviewing internally.
Okay.
To see where, where they are with it.
Okay. Well, we're here to help support and facilitate. I don't know what the wait list is for residents that need to be seen. Can you expound on how many people are currently on the wait list?
So right now, we do have our largest wait list really lies with the general dentist appointments. And a lot of those, majority of those are coming out of the Gaithersburg Clinic Metro Court. The hygiene appointments, we've been able to improve those, and with new hygiene positions as we fill them, that will help also. But the biggest are the general dentist appointments, and that we would love to be able to help send patients over there, so that could help.
Yeah, so is there a letter that we can send on behalf of the committee to facilitate expediting a response, or?
I don't know that we need a formal letter. How about a phone call?
I would do a phone call,
All
yeah.
right. Yep.
Yeah, whoever we need to call.
Awesome.
Thank you.
Great. Great. Thank you all very much. So I think without objection, then we'll agree with the recommendation set forth. But in acknowledgement, we're going to come back with a broader investment that will be recommended by the collaborative. All right. Thank you.
Thank you. So just to be clear, I should have started the conversation saying we invited the county dental program staff to come as part of the base budget reviews. So we looked at Office of Community Affairs. This was the section on dental. So thank you so much to the staff for the update. Under county dental service, there are two increases recommended for the budget. One we talked about in detail. So the 7 FTEs at $800,000 is before the committee. Council staff recommends approval. We note that it's a significant cost, but will only increase the general dental capacity and also capacity for specialty services.
Without objection? Yep, without objection.
Okay, and the next item is it's an increase of cost, the final year of a phased merit conversion of previously contracted dental program staff in the amount of $110,000 in 5 FTEs. So last year for FY24, the council approved converting 9 positions in dental services from contract to merit positions. It was noted that merit employment will allow more flexibility in the assignment of staff to priority areas as needed and support a balance in management and supervision, and overall help to improve workflow. The positions that would be transitioning are 5 principal administrative aides that will become merit. Council staff did identify this as a potential reduction. As instructed, we reviewed the budget items and considered that this could be could be a reduction. If the council approves the expansion positions that we just talked about, that at least 2 of the merit principal administrative aides will be hired. I do want to confirm with DHHS that if the committee confirms this reduction or identifies this reduction, that those merit staff would still stay on the contract for FY25 and be considered again for maybe FY26. I just want to make sure that if we don't approve them, what would be the option? Can they stay on their current contract? And that would be council staff's recommendation.
Jason, did you want to tackle that one?
Everybody's looking at each other.
Yeah. So, Jason Rundell, budget analyst for HHS. The challenge is that based on legal advice and other advice, having staff work side by side doing the same work that are contractual staff and merit staff is a great problem. Besides we've been under direction to move away from contractual staff and permanent positions together, but with the approval of 2 new PAAs that would be merit staff, to keep contractual staff on there would cause a great inequity and some challenges. So we would strongly recommend against the recommendation to reduce this, as it's a needed conversion of these positions or creation of these positions for permanent staffing. The question of whether it could be continued, we'd have to visit that. Obviously, we need these services. We need to do something, but it puts us in a challenging situation.
I can speak from firsthand experience about similar challenging situations when I worked in the executive branch, and it creates exposure that creates low morale and legal issues. And so, and I do believe that we're building some momentum here around our dental programs, initiatives, infrastructure that I don't believe we want to take our foot off the gas from, that we need to continue to move forward. And so I appreciate and respect Ms. Clemens-Johnson doing her job and trying to make the least worst decisions as we go through these tough decisions within HHS, but I, for one, will agree with the executive branch recommendation on this. Any other questions or comments from colleagues? No? Do you agree with the executive branch recommendation? Yes. So without objection, we'll go with the executive branch recommendation.
Thank you. The next section is under the Healthcare for the Uninsured programs. We'll start with the Montgomery CARES program. In your packet is a detail of the budget and also a summary of the Montgomery CARES program. It is 10 clinics with over 25 locations, and they serve our uninsured and uninsurable residents of Montgomery County. The recommendation for FY25 is to increase the Montgomery CARES reimbursement rate to 50% of the cost of care as identified by the partners who participate in the program, of $1.8 million and 0 FTEs. In FY24, the council approved an increase in the rate, and you'll see the chart in page 13 of your packet, ghost numbers. So last year the rate stayed the same for FY20 to FY24 of $76.50. So there was a increase of around $25 last year, and this increase that is recommended for this year is about $25. So we'll note that last year and coming out of COVID, Montgomery CARES providers were paid through a block payment, which provided some predictability at the time. With COVID, there was wanted to ensure some type of sustainability for the clinic providers, but DHHS has returned to the system of providing reimbursement per encounter for the clinics that participate. The executive recommendation is a 22% increase in the rate, going from $102.15 to $124 per encounter. Council staff's recommendation is to split this into 3 tranches. The first being $1 million, which would be a $15 increase, including direct and indirect costs, and then 2 tranches of $360,000 each, so 3 tranches. We recognize the need to better compensate the clinics for the cost of care, but as the increase is so much above other certain adjustments to contracts, we suggest that a somewhat lesser amount might be appropriate, given the other fiscal constraints that the council has to consider. So that is the recommendation: 3 tranches, $1 million, $360, and $360.
So I do have a few questions about this, and I appreciate the recommendation, once again acknowledging our challenging fiscal situation. Dr. Bridgers or Dr. Ashford, we did hear testimony from colleagues that in this space that what the county executive was proposing was still not enough to meet the demand and needs and lessen that delta of what they are reimbursed and the challenges that they are seeing. Could you talk a little bit about, from the executive's perspective, why you propose this number and not a higher number, and what you're seeing?
Thank you, Councilmember Alvarado. So from the executive branch and from the team's assessment, we've spent a lot of time looking at value-based care, cost reimbursement systems and models, and reimbursement parity. We've met extensively with our Montgomery CARES partner, and there's a wide gap in service provision and cost reimbursement models and systems. The executive recommendation would align the reimbursement percentage more akin to what the national average is projecting from a cost reimbursement or healthcare model. COVID provided us with some flexibility and leniency But now we are faced with the reality of having those providers not being able to provide the services. Because if an individual who is underinsured or has no insurance is not able to provide a provider, they go without health care. And so I will stop there and let Dr. Rogers and Dr. Ashford add to that, because they've been instrumental in following up and providing a cost reimbursement model that really meets the needs of the community. And it's consistent with what the council executive recommended.
Thank you.
The only other point I would add before turning over to Dr. Rogers is that when we look at the individuals who are receiving these services, they are often have multiple chronic conditions, high social determinants of health needs. And so when we think about what the reimbursement rate is for them, it's not going to be akin to a privately insured patient who might be 30 and healthy and, fully employed. And so they do require more time, more services, and investment on behalf of the providers. And I'll turn it to Dr. Rogers.
I think I would just say that this is a step in the right direction towards reaching the reimbursement threshold that the Montgomery Cares Reimbursement Work Group agreed upon. I think it was 2 fiscal years ago. And so we know the budget realities, and so we support the county executive's recommendation in FY25.
I appreciate that. I think the tranches approach is risky. I'm anxious about it because I think we need the full amount, but to be consistent with what we've done in other categories, I'll support the staff recommendation. But what I'd like to request, because I'm going to push hard for all 3 tranches, is that you all, with help from our care providers, provide specific examples of what wouldn't be able to happen under those 3 different scenarios. And we'll see where we go from there. But, this will unfortunately compete, with all of the other line items that we're going to be discussing from all of the prospective committees. But Councilmember Lukey and I just attended the ribbon cutting ceremony at the Casement Clinic yesterday and had the opportunity in the first person to speak to the staff. And that is a magnificent facility. It raises the bar for all of our facilities moving forward. But it just underscored the need for us to be able to make those organizations whole, because they end up having to eat so many of those costs themselves. And while they fundraise and they do a lot of really wonderful work, we can't expect them to continue to do all that they are doing without it not impacting public health. So we'll go with the staff recommendation on this, but we'll need extra talking points to make the strong argument we need all 3 tranches.
Okay. Our next item is Care for Kids. This is our program providing healthcare services to children in Montgomery County who are uninsured, in many cases uninsurable. And included in your packet is Care for Kids enrollment. We have almost seen 10,000 children, which would be record for the program. I think the numbers have constantly increased since the program began. We haven't seen a decrease in a number of years. So the first budget item for Care for Kids is access to reproductive health, $180,000. This funding will support youth enrolled in the program to include counseling, a wide range of contraception options, and follow-up care. Council staff recommends approval. This item would go on the new and enhanced program list if approved.
Without objection?
Yep. Okay. And the next item is administrative support to accommodate the Care for Kids program enrollment increases in billing capacity. The council staff recommends approval. I believe this would go straight to the contracting agency.
Without objection?
Yes.
Yep.
Okay. We will start with the next program section, which is health planning and epidemiology. The first item is a federal grant to enhance detection, response, and prevention of emerging infectious diseases. This is $2.4 million. This funds will be used to support capacity for outbreak response, infection prevention and control, and enhanced testing, particularly for vulnerable populations. Council staff recommends approval.
Without objection.
Okay, and the next is a grant for $430,000 supporting public health infrastructure. It will fund a program specialist and a dental hygienist, and this grant will end at the end of FY27. Council staff recommends approval.
Without objection?
Okay.
Sorry about that, Councilmember
sorry.
Sales.
Sure.
This program has been underway since...
This grant?
Yes, the grant. How long
I
has it been?
believe this will be the first year of this grant? Yes, I believe. Oh, go ahead, Dr. Rogers. Or second?
So we received the LHD Local Health Disparities Grant. Is that the infrastructure grant? Yeah, so we received that at the start of FY24.
Okay, and do we have any updates of what's happened the past year?
We can get you some update. Let us get back to you. I know we've hired a number of positions to support with infrastructure, like in our epidemiology team, Dr. Liu's team, I believe. A couple of our programs have benefited from that grant, so we can get back to you.
Okay, it would be good to see if they're looking at any targeted information to help us target the work we're doing with our minority health programs. Okay, thank you.
I can respond to that. So the LHD Health Disparities Grant that you all heard about earlier today, the Minority Health Initiative programs all received about $80,000 from that grant in order to address COVID-19 health disparities. They have been working on that since the beginning of FY24, and that grant from MDH concludes this year. They have had success in serving individuals, and based on that question, we're happy to share some information based on that grant as well.
Yeah, just because of the amount that was spent for FY24, it would be good to find out what they've learned in this past year and what they plan to focus on for the remaining years of the grant. Thank you.
Great.
Okay.
Next.
The next program area is licensure and regulatory services. Just want to note that this section is responsible for enforcement of state and local laws regarding food service facilities, smoking in public places, swimming pools, camps, ferment control, private educational institutions, group homes, short-term rentals, hotels, and various other business licenses. So in FY23, there were food service facility inspections only was 5,459. And the number of required inspections is projected to increase. And so the personnel was included, and there are 33 positions under L&R. The 31 are currently filled. There are 2 vacancies right now that are detailed in your packet. The first recommendation includes an increase to add staff to review capacity and assist county businesses with attaining licensure and complying with regulations. This is $89,000 and 1 FTE. Council staff recommends approval. The number of facilities that require inspection continues to grow, and additional staff is needed to meet the requirements. There is extensive detail in your packet about what that position will do, and DHHS can also provide any supporting information.
Councilmember Lukey has a question or thought, and then after she does, for the millions watching at home, if you could just tell what that position will do. It's in the packet, but for purposes of our public discussion.
Thank you. Thank you for including the statistics specifically about the food services facilities. But again, I note in the little summary there, it lists the panoply of different things that need to be inspected and checked that fall within the DHHS bucket. It's not really a bucket, it's vast, much bigger. And certainly licensure and compliance is near and dear to my heart, but I have concerns that we only got 61% of our mandated inspections in one bucket of area of work, and we don't have information about the others. I know we did speak last week with Dr. McGee about the nursing home inspection issue and the state-local back and forth, and I appreciate that you all are working on that, but What, if any, I mean, I don't have any problem with the funding recommendation, so let me just put that out there. But what plan do you have moving forward to help to facilitate getting us fully up to where we need to be in terms of completion of inspections? And I'm assuming there's mandated inspections which are required on an annual basis for facilities or at the time of an opening, et cetera. But there are others that are complaint driven. So how are we managing the triaging of the complaint-driven parts of things that fall into all these areas versus the mandatory things in all of those areas? And everybody's going to push a button. Oh boy, I asked a big question.
Thank you, Councilmember Lukey. Let me just provide some contextual response to your question. We have looked very deeply into this challenge. We've looked at comparison models in neighboring jurisdictions, principally Prince George's County. We looked at the efficacy, what works, what doesn't work, the number of lists, and all of those regulatory items that are mandated by COMAR.
Right.
I also want to thank Councilmember Fanny Gonzalez for her expressed interest in this piece. I've had some conversations with her as well about the need across the county. But we have given this some thought. Dr. Ashford has worked with me, and we have asked Mr. Welch to provide that granular level detail. We don't have any backlogs. Let me just say that we have worked very diligently to address the concerns. We've also presented this request in previous council fiscal cycles, so we recognize the need. This year, we've also looked at some split models. I've had conversations with Director Sabakan in permitting, at other models to look at a health review team versus an inspection team. The pros and cons to that is that if the inspection team on the permitting side does it, it's not validated until the health side does it.
Right.
And so looking at all of that and taking all of those variables into consideration, we strongly feel that the executive's request is a valid one to be able to meet the needs of the community. I'll stop there, but I'll ask Mr. Welch to give you a little more detail about the checklist and things that our L&R team looks for.
And as you're pushing your button, I will say thank you, because I know that our business, when new businesses are trying to open and they've got 2 different times for 2 types of different inspections, but everything's got to jive at the end, the business side is definitely appreciative if it can be done together. So that helps a lot.
Yeah. So for fiscal year 23, we did have 4 vacancies. We were able to fill 3 of those 4 vacancies, which still we have a vacancy for one of those. Regarding your question, how do we triage the complaints versus normal routine inspections?
Right.
Complaints, the staff are required to investigate within 3 to 5 business days. So that takes priority. We do have emergency complaints that come in that we require them to do every 1 to 3 business days. So we jump on the complaints and try to get those foreclosed first and foremost, so that we're not getting caught behind on normal routine inspections. And yes, we do have state mandates that we are required to fulfill. So part of this problems that we've been having is that there just aren't enough staffing levels out there. We generally steal people from other counties. The other counties just don't have the staffing level. There's a reduction throughout the nation of the licensed inspectors. So right now we're trying to figure out a better way to do this, but there's not much we can do without the personnel that's there for us to do it with.
Right. Right. And is there, is this something that has been brought to MACO's attention in terms of, because again, it's not just our problem, it's a bigger problem.
Yes, absolutely.
Yes.
MACO is very much aware. The state's aware.
Good.
So there are things in the process that they're going through. They have a working with Morgan State University to try to do an internship program with the state and local jurisdictions to try to bring people in the science degrees into the local jurisdictions, get them excited about the program and about the profession.
Great. Well, you just touched on another hot button that I love to talk about, which is apprenticeships and internships. So thank you. That's good news.
So thank you, Councilmember Lukey, for that. But for the record, Mr. Welch is the chair of MACO's Environmental Health Committee, so he takes everything to heart and takes it back to the Environmental Health Committee on behalf of Montgomery County.
Thank you. And I would say, just to add and answer Chair Albornoz's question about what this position would actually do, this position is going to be responsible for basically education and outreach with the business community. So we want to help them have the knowledge and the information to be able to navigate through the permitting processing, to limit the number of backs and forths, which then increase the number of days it takes to get a permit approved and ultimately go through the process and then be able to make money, which is why they opened a business, right? To provide a service and to be able to support themselves with their business. So it's the position will focus on customer service, and they're going to be a facilitator rather than a regulator to really try and help streamline and work through some of those kinks, both with health inspections, but if other, as there always is, with other permitting, our colleagues over in DPS as well. So that is what this role will do, with a focus as well in partnership with our minority-owned businesses.
Great, thank you.
Councilmember Sales.
Yeah, so if 60% of only 60% of the businesses received an inspection that were mandated, the other 40% are rolled over into fiscal year 24?
No. Basically, all the businesses got at least one inspection.
Okay.
But depending upon the priority of the facility, it's broken down per state regulations as a high, moderate, and low priority facility. High priorities you get 3, moderate priorities you get 2 inspections, and low priority gets 1 inspection. So we've hit all the facilities. It's just we may not have hit it 3 times in 1 year.
Okay.
We may have only got to them once or twice in the fiscal year. But that
Okay.
does not roll over to the next year.
Okay, so we do have 100% compliance with the state regarding visits in 23 and 24.
We do not have 100% compliance because we have not been meeting COMAR as far as the frequency and the number of inspections that are required under the state regulations.
Okay, and so there wasn't a recommendation for an increase in staff for completing those additional visits? It's just an outreach and education request?
Part of this position is also because the businesses, it will increase the inspections because the inspectors spend a lot of time in these facilities educating on the laws and the regulations. So instead of going the enforcement route with these businesses, this position will be able to, once the inspector sees that they're having trouble being able to apply the laws and regulations or simply do not know the laws and regulations, this can be a training platform for those businesses as well. So instead of going the enforcement route, we can schedule or some type of training with the individuals so that they can get up to speed and it's safer for the public.
Okay, because I'm just worried that, just trying to understand how many outstanding visits we have from, if you don't do all the visits, how are they reprioritized in 2024?
No, it's based off of what they do food service wise. It's how they're prioritized.
Okay.
So basically, if we're not able to get the inspections done or we're having problems with certain businesses and we're spending a lot of time with those businesses and can't get to the next businesses, this position can go in and train those businesses or assist those businesses.
Okay.
So that we can get to the next business.
Okay. And do we have the numbers for 2024?
Not at this time.
Not yet? Okay. Will we be able to get those numbers of how many businesses were visited for FY24?
Absolutely.
Okay, thank you.
Thanks. So I'll just wrap this line item up. I do, as Dr. Bergers noted, want to acknowledge our friends in the Economic Development Committee who passionately had a conversation about this just a few days ago. And Chairwoman Fanny Gonzalez, who I know indicated she was going to be reaching out to our committee specifically regarding this particular line, and I'm strongly supporting not just this recommendation, but seeing how much further we can go beyond it. We should have that conversation post-budget. I'd also be curious as to, when we do have that conversation, benchmarking what this position will be focusing on, how many business and establishments, how are they leveraging existing staff and resources, whether it be through MCEDC or our permitting office or the various channels that we have to reach our community, because it is, at the end of the day, just one position, which will make a difference for sure, but they will quickly be overwhelmed. And we have to make sure that whomever fills this position understands and is prepared to meet the community where they are from a cultural competency standpoint. Because many of these restaurants are ethnic and culturally based, which is wonderful, but it also, we want to make sure that we're meeting them where they are. So I think without objection, we will agree with this recommendation, but revisit this in a joint session further into the year.
Okay, thank you. We will move to the next section, which is program area, emergency preparedness and response education. The recommendation is $595,000 for ongoing infectious disease prevention, response, and community support. This one-time funding for COVID response readiness included in the FY24 general funds is being replaced. This replacement will provide a reduced level of service in FY25 as it removes the cost of rapid test kits through the libraries. So council staff recommends approval. While there are FY24 funds approved for the same purpose, it is a reduction. Council believes that the categorization as a replacement means that it will show on the new and enhanced programs list. We would like the DHHS to clarify if this funding is intended to be ongoing or considered as one time.
Can you all answer that? Great.
Yes, good afternoon, Sean O'Donnell. Pleasure to be here with you again. To answer that question directly, this would be ongoing funding. This is enhancing the disease control and response measures that have now been elevated consistently since COVID. In particular, are the number of outbreaks that happen at congregate settings, at nursing homes, where we're still seeing a majority of the serious illnesses. Those have gone up astronomically. Prior to COVID, the years prior to COVID, it was 14 outbreaks in 2018, 28 outbreaks in 2019, and in 2020 there were 36 non-COVID outbreaks, 485 COVID outbreaks. And those COVID outbreaks have continued in each subsequent year, 510 in 2021, 478 in 2022. So our staff is still responsible for following up with those, doing contact tracing in those settings, and working with the nursing homes and assisted living facilities to try to curb those and reduce the morbidity and mortality from that. So that's the largest piece of this. There's also funding in here, $50,000 for each of our minority health initiatives to do enhanced outreach and education with our communities. We saw this past year as the vast majority of vaccinations have been shifted to the private sector, that all populations have gotten reduced levels of booster vaccinations, but none more so than our minority communities. And so we want to do more education there. There are programs to offer a vaccine either through insurance or for uninsured individuals, but we're having difficulty raising it to a level with those populations to get them to come out and get those shots. So this would be ongoing funding for those. And there's a small amount for testing in our congregate facilities that the county supervises.
Thank you for that clarification. I don't see any other questions from colleagues, so without objection, I think we'll agree with that recommendation.
Okay, and this ends the recommendations for public health services. The next section will be minority programs under Office of Community Affairs.
Great. Thank you, Mr. O'Donnell and Dr. Ashford. And Dr. Rogers. All right, we can keep going.
Okay, thank you. So the minority programs include the African American Health Program, the Asian American Health Initiative, and the Latino Health Initiative. And in the last few years, the Black Physicians Healthcare Network has been added to the portfolio of minority programs in the Office of Community Affairs. On page imaginary page 18 of your staff report, there is a chart of the approved budgets for the programs for FY24 and FY25. And the staffing complement for AHI is 9. For AHP, it is 4, and for LHI, it is 16. The African American Health Program has most of its program staff through a contract, so it's not shown here. So just highlighting the African American Health Program, there are no budget recommendations for this year, but in FY24 there was significant funding added to the program. Medication therapy last year was $150,000. There are, so far this year, there are 50 seniors that have enrolled to receive medication therapy management with local African American pharmacists, and are 75% completed. In the health and education and wellness space, there was $550,000 approved. The AHP highlighted the programs and services that they have begun to do education on, including sickle cell, complementary and integrative medicine, fentanyl, and opioid awareness. And they have been doing this through summits, health education programs, and resources. They also mentioned that they have hired a substance abuse and mental health contractor to focus especially on fentanyl and opioid awareness. And the SMILE program has been around for years. SMILE stands for Start More Infants Living Equally Healthy. There were 366 women enrolled in SMILE in FY23. As of March of this year, the program has served 274 women. So we will move on to the next program and the recommendations for the FY25 budget. The next program is Asian American Health Initiative. There is $150,000 recommended for the micro grants program and patient navigator program. So of the $150,000, $50,000 will be added as an enhancement for the micro grants. This will be added to the FY24 approved amount of $100,000, and these grants are distributed through a contractor that AHI has. And then the $100,000 portion of the funds will be an enhancement to the patient navigator program. They have listed their expected outcomes in the packet, and the council staff recommends approval of the funds.
Just state up front, can't thank again enough our minority health initiatives and program for their dedication and leadership. They are continuing to build bridges in the community that the county government cannot do on its own. I want to thank you, Ms. Lamb, who I know have shepherded your support for these organizations along with your team, and I know how appreciative they are because they tell me all the time. And so I don't see any questions or comments. Oh, Councilmember Lukey and Councilmember Sales.
First, I want to say thank you for the recommendation on the Latino Health Initiative, especially with respect to the expanded community health worker training program. That's really working well, and it is a phenomenal program assisting with meeting the needs out in the community. All of these programs do incredible things, but that one in particular I felt I wanted to give a shout out to. My question is, after speaking with the National Center for Children and Families and thinking about this year's legislative session, and they finally got over the hurdle for passing to allow those who are don't have citizenship to be able to apply for benefits on the Maryland Benefits Exchange, knowing that there's going to be some time that's taken in order to get the approvals from the federal government and get everything up and running.
But how do you think the prior recommendations of the Committee on Health, which they've made again this year, to request a senior planning specialist to analyze the 5 healthcare programs for uninsured or underinsured individuals and assess the functionality. Do you think that that is something that is necessary now as you plan to move forward, knowing that there's a different landscape available that will be available moving forward to provide insurance coverage for a large chunk of our population that falls in these programs?
I'll just state that the Commission on Health letter wasn't included in you all's packet. That recommendation was regarding the healthcare for the uninsured program. So they were talking about like Montgomery Cares Care for Kids in terms of the planning specialist being in that area or program area of the budget. So I just wanted to, I saw everybody flipping through their documents.
Okay.
Yes, so thank you for that. That's a significant piece of legislation that has moved its way through the Maryland General Assembly and will have a significant impact on our health care for the uninsured program. I mean, we know that it in effect includes our entire population. They will now be eligible for QHP. And so in FY25, what the department will do is that we'll be working with our community stakeholders to come up with some recommendations on what the program would look like as a result of that impact, and bring forward some recommendations to the county executive as well as the county council for starting in 2026. We have a year really to come up with some recommendations. As it pertains to that position, I believe that position is necessary because there's going to be some tactical work that is needed in order to make that transition for what a future program will look like. And so having that position will be critical over the course of FY25 as we make that transition. We know that these individuals will need some support because that legislation does not offer subsidies or does not offer financial support. And so what is the true impact of that legislation on these individuals? We think we know anecdotally, but this position can help us really gauge the impact to our patient population as we prepare for 2026.
But I know one of the intents behind the legislation is also to alleviate burdens on, some counties, Montgomery being one of them, are disproportionately affected by the fact that folks can't get insurance, and the impacts on local governments in trying to fund and make sure we're caring for people in the appropriate ways. It becomes significant when there's no outlet other than that, right? And so, I am very interested in seeing what kind of assessment comes out as to the overall impact and how that would shift and adjust what we've been doing in other spaces, because in theory, if this is working well, it should reduce down the expenditures in the other entities. It doesn't mean they would disappear completely, because there's always a gap in time between trying, educating someone, getting someone onto the program, making sure there's not a gap, that they didn't fall through the cracks, et cetera. So it wouldn't be a complete swap out one for the other, but it should, in fact, change the landscape significantly moving forward. Thanks.
Councilmember Sales.
Yes, I was just looking at the staffing breakdown across the 3 minority health programs, and I noticed that the African American Health Program had 4. Is that correct? I know they use contractors, but just wanted to better understand what the staffing levels are and why it's
good afternoon.
So different.
Betty Lamb with the Office of Community Affairs. So yes, the number of merit staff with the African American Health Program is 4. The program, when it first got started in 1999, has the model of outsourcing the primary program activities to a contracted partner, and it has kept that model for since that time, and have chosen to keep that model for until now. So the vendor actually has a big number of staff employed through the funding given by the county to run those programs on the county's behalf.
So the approved budget, it's for the 4 staff in addition to the other contracted work, or is the 4 staff different?
It is for the staff, the 4 staff, and the contracted services.
Okay. Okay, and then I just had a question about the AHP brown bag series.
Yes.
Yes, so I'm just, I see that there is a request for an increase for that program, and just wanted to know what, I guess, precipitated that specific program.
That specific program is mainly aimed to help with senior population in the African American Black community, county residents. So there isn't a request to increase for FY25. The increase was in FY24, and it was through advocacy from the committee as well that the senior population in the Black African American community is on the rise in the county, and so they wanted to focus on helping seniors in terms of the various needs and understanding of the services that might be available either through county, through our own aging and disability services, or by community partners.
Oh, okay. Okay, because I know that there's some other priorities. I just wanted to better understand how they chose this as a priority, because it's going to go on the new and enhanced list, and so I want to make sure that we have enough information to justify its continuation.
Just to be clear, the updates, the AHAP information included in your packet is just updates from FY24, so there isn't a budget recommendation for FY25 for AHP.
Okay, so it's not new, it's just an updated.
Right,
oh,
right,
okay.
right. Yes.
Okay, oh, good. Okay, and then I'll ask about the last program, the health education and wellness. I know that we've heard that a lot of our teens are having trouble with the fentanyl and opioid usage and overdoses, and wanted to see how this program is going. I see it specifically targeting young men, but it's 18 to 45. Is there a need for our youth under the age of 18?
I would believe that it would be, and it would be a program and the activities that we would want to coordinate very closely with our behavioral health and crisis services. So this is a relatively new component within the African American Health Program contracted services.
Okay.
So it is only just started. So I would imagine that the coordination would be happening right now.
To expand for the young people?
Yes.
Okay, okay. All right.
And this is not an increase for FY25.
Yes, yes, it's just an update. So when I saw that it was happening, I know that when Dr. Davis was here a few weeks ago, she mentioned the uptick in our youth. And when I saw the age, I was just wondering if there's another line item directed for our youth, or if there's going to be an opportunity to expand this program to include younger men.
There are right now continuous conversation between our AHP staff and Dr. Rolando Santiago's staff around how to target education and outreach on this particular issue, and I would believe that the youth part of it would be addressed as well.
Okay, all right. If we can get any updates on how we're targeting our young people, that would be great.
Sure. Thank you, Councilmember Sells. Let me just add this. So from an integrative perspective, Ms. Treadvance and her team from our Children, Youth and Families, Dr. Santiago from Behavioral Health and Crisis Services, Dr. Davis through the Youth Safety Initiative. So we are targeting at-risk young males, Black and brown males, and it's part of our ongoing effort. We know summer is here. and so we're planning for that now. So we've had conversations not only internally but externally to our community partners. So that is part of that. Some of that is integrated in some of the executive's budget over time, but they are integrated in the work that we do. So it may not be part of an enhancement, it may be a continuation of previous work, but it is happening.
Thank you.
All right, thank you for those clarifying responses. So I guess without objection then, colleagues, yep, we will concur with the recommendation.
Okay. The next item for consideration is the Latino health initiatives. We have included updates as well as the budget items. And so the first item is an update on the Encuentros program. Apologize if I'm saying that wrong. I did want to highlight that there was $832,000 approved in FY24 to increase the number of groups from 64 to 100. The program has grown exponentially, and they actually increased the program to a total number of groups to 147 for FY24. And for the next program, expanding health promoters outreach, $120,000 approved in FY24. Their target was to reach 15,000 additional community members, and they have reached 33,000 as of so far in FY24. So we just wanted to highlight the utilization of the funds from last year and how those programs are progressing.
And just a point of privilege, I've attended the graduations of these programs, and they are amazing. This is a great example of what's working in our community.
Awesome.
So without objection.
So the first item is the Latino Health Initiative Steering Committee's request for expanded community health worker training program, the Welcome Back Center expansion, and enhanced communication, $300,000. So each of those programs has requested $100,000. The Community Health Worker Certification Program, the additional $100,000 would allow LHI to offer 2 cohorts of the certification program to 25 community health workers. There is a current wait list of over 65 plus residents waiting to start the next cohort, so they are stating that you could utilize the funds to support that. The Welcome Back Center, $100,000 for that program to serve an additional 75 participants. The $100,000 is distributed as financial aid to the participants of the program, and there is detailed breakdown of potential funding items in your packet. And the last item for $100,000 is communication activities. It supports digital communication on several platforms: radio, TV, social, and digital media. And LHI did note that they have been working with the Primary Care Coalition as a contractor, helping to support that work. So staff recommends approval. This item would show, and so I talked about 3 programs, $300,000, $100 each for LHI, and this would go on the new and enhanced program list.
Without objection.
Okay, and
question, Councilmember Sales.
I'm sorry, just had a quick question about the LHI. Once the health workers graduate from the program, how many people are in the cohort? Like, I know it's 25 people in the cohort, but this has been going on for quite some time. What are they doing after they graduate, and how are we using that information back at HHS?
So this certification program is actually new, because it's a Spanish language certification program that was accredited by the state. And so when they've gone through the 100 hours of sessions and then 40 hours of practicum, then they are considered at the state level as certified CHWs. So it's a little bit different from the health promoters in the past, where they did not go through the certification process. So this program is relatively new.
And so are they connected with job opportunities afterwards, or is this an ongoing?
It is not considered as a workforce type of a program. However, the ability of them getting that certification actually professionalizes the health promotion education piece, so it will open doors to healthcare-related fields that they could certainly begin to look into. But it's not necessarily right now billed as a workforce type of a program, but it does have that element in it.
Yeah, I'm just thinking about the workforce shortage that we have in the healthcare industry, and we're already investing in training and preparing these workers to go to the next level, and I'm just wondering why we haven't gone to the next level to connect them with pathways to continue their training with the Office of Workforce Development, with Montgomery College, to fill that increasing gap that we have, especially because of the cultural competency that this workforce brings. I just feel like it's an untapped opportunity. And we're doing 25 people per cohort. There's already 60 people on the wait list. I mean, we have the worst emergency room wait times in the state, and here in Montgomery County, it's bad. So I just would love to hear more about how we are connecting these workers with some of the unmet job opportunities that are continuing to grow, are outstanding. It doesn't make sense that we're not capitalizing on this program and building upon it to get these folks into these positions that are so desperately needed.
I do think that that's where we wanted to move toward.
Okay.
And I'll be happy to bring back more information
Yes, would
about
love to.
how they're going to, yes.
Yes, awesome, thank you.
And thank you, Councilmember Sells, for that. I will bring this to the attention of the Source Montgomery Board the next time we meet as not only, and we've had conversations about this in developing.
Yeah, we were just
pipeline.
talking about this with the Econ Committee and potentially having a joint discussion about this, so.
Thank you.
Sounds good, thank you.
Great. Without objection.
Okay. And the last item in your packet is update on the Black Physicians Healthcare Network. There was not a FY25 recommendation for funding, but we did want to request more information about the status of the program. So there are numbers in your packets of the folks they served. This program covers the cost of co-pays, deductibles, and they do navigation and some outreach for BPHN clients in Montgomery County. And with that, that is the end of our public health services program area.
All right. Thank you all very much. Why don't we take a 2-minute recess just to use the restroom and get some water, and we will come back. Mr. Treadvance, thank you for your patience. We are there. We're getting started. 5 minutes. All right, why don't we re-engage? So thank you all again. We move on to the final item of our agenda in this part of the HHS budget review, and that is our Division of Children, Youth, and Families. Ms. Yao, I'll turn it over to you.
So the committee is going to be talking about various items in Children, Youth, and Families that are not going to be reviewed by the Joint Committee tomorrow, that do not have to do with partnership with the school system or are not education related. So for the service area in fiscal year 25, the executive is recommending $124,956,000, and it's an increase of about $4.2 million or 3.5% increase from the 24 approved amount. There's a total of or a net of 4.59 FTEs that are being reduced from the service area. And on page 2 of your packet shows the 8 programs in the service area, provides a description of each, and includes the changes from 24 to 25 in terms of funding as well as FTEs for each program. Moving on to page 3 of your packet, the table at the bottom of the page shows the changes as we would group them according to the Council President's method of reviewing the budget. So we see that we have new and enhanced programs, shift and transfers, program adjustments that are required by law, service continuation, and recommended reductions that we'll walk through as we go through the packet. The first item for review is child welfare services. For this program, the executive is recommending an increase of $100,793 to add 2 community service aides to the program for service delivery and transportation. These are needed to supervise visits between children and family members and do a whole host of other kinds of activities. But this is particularly needed because the court has ordered an increasing number of family visits, which can be very time-consuming for service aides. They can take up to 6 hours, inclusive of the transport time and actual visits. And some children may require 1 visit per week. Some cases may require 3 visits per week. So and this work cannot be done by contractual employees. So in order to fulfill the mandate, the legal mandate for supervising court visits, this is being recommended, and council staff recommends concurring with the executive.
I don't see any questions or comments from colleagues, so without objection, support that recommendation.
The next item is moving tax supported chargebacks from DHHS to the Office of County Attorney, total of $105,175 and 0.5 FTEs. OCA has typically charged staff time to other departments and funds, and apparently this is a very significant administrative burden both for the Office of the County Attorney as well as for the using departments. And in order to ensure that OCA can fully fund its complemented attorneys and staff, from year to year, they're recommending these chargebacks. The GO committee reviewed this item overall on April 11th and recommended approval, and council staff recommends approval of this particular item.
Without objection, colleagues? Okay, let's move on.
The next item is the Treehouse Child Advocacy Center of Montgomery County. It's an independent nonprofit that partners with the county to provide a single location for services that reduce trauma and promote healing for child and adolescent victims of sexual and physical abuse and neglect. For 25, the executive is recommending $774,299, which is a 3% increase over the fiscal year 24 level of funding. The projected total revenue is projected to increase by the Treehouse by $302,779, and the Treehouse anticipates that county funding will be about 52% of total revenues. The service data for the Treehouse at the bottom of page page 5 shows that there has been an increase in services, particularly mental health services and family advocacy since the pandemic. In addition, council staff provides some information about the wait list at the Treehouse. So for the first 5 months of this fiscal year, the program wait list averaged about 6 English and 11 Spanish speakers, and there was a wait time of no more than 4 weeks. However, the waiting list has been reported to be growing the past 4 months. Due to increased volume of referrals, a new group therapy program that's taking up therapeutic staff time, Spanish-speaking therapists on maternity leave, and the elimination of a forensic interview position. So council staff understands that council members had gotten communication from the executive director and the board president of the Treehouse asking about this particular position. And from what HHS has explained, prior to the decisions of fiscal year 24, there was an agreement that the county would continue funding that forensic interviewer position through 24, and that the Treehouse would assume that funding after that. Because of issues with the contractor and the county attorney not being able to cover legal issues related to a contractor, that contract with Athena, which was providing the forensic interviewer, was terminated mid-year. But in order to cover those services, child welfare provided trained staff to do that. However, as of April, the Treehouse decided that they would take one of their therapist positions and turn it into a forensic interviewer because of the importance of that position. It's critically important for both the organization as well as child welfare services. So certainly, Treehouse has indicated that the conversion will reduce its capacity to deliver therapeutic services. However, they weren't able to quantify to what extent that would happen. And they have reported that they would increase client services expectations for its therapists, as well as increasing the productivity of their mental health team, as well as searching for more funding for more therapeutic positions. Council staff is concerned about the capacity of this organization to provide these, critically important services for this very vulnerable population, and recommends that the committee seek more information about what options there are to address this need for both English and Spanish speakers.
Both colleagues have questions. We'll start with Councilmember Sales, followed by Councilmember Lukey.
Thank you for the report. I had questions about the current wait list. How many people are currently on the wait list?
Good morning. Morning, afternoon.
Yes.
We do not have those numbers. It has been a long day. I'm joined by Lisa Merkin, who is our program administrator for Child Welfare Services. I don't believe we have those numbers, but we can reach out to the provider and offer that after the session.
Do we know approximately how many?
Not at the moment.
Okay.
Thank you.
And do we know what they are waiting for? Is it an entry interview? Are they waiting for a medical exam, forensic interview? I mean, these are, I thought, like urgent matters.
Good afternoon. Lisa Merkin from Child Welfare Services. They are not for forensic interviews because those are time sensitive and those need to be completed immediately. The same with the medical exams. This would be for therapeutic, clinical needs of children. I will say that if a child's in, speaking for the Treehouse, if a child's in urgent need, that those are, of course, prioritized, and or other community resources would be looked at.
Okay. And what is the current staffing level at the Treehouse Advocacy Center?
Would need to get back to you on exact numbers.
You said 2 staff?
No, I'd have to get back to you on exact numbers in terms of number of therapists.
And you're the program administrator?
No.
Oh, what's your
I'm the
title?
I'm sorry, yes, I am for Child Welfare Services, but the Treehouse is a nonprofit with their
Okay.
own executive director, so that exact number I just don't have. in my
Okay,
mind.
yeah, if we can get that information, I think it would be helpful as we're making a decision about, how these funds are going to be allocated, the $774,000. Are they being used to hire more staff, or? Okay.
That would be a question for the executive director of the Treehouse.
Okay.
So
We can
thank you,
get back to you.
Councilmember Sells. Let me just jump in here. So this is a complex issue where we've consulted with the Office of the County Attorney for the work that we do in the forensic interviewing, and so we were using brokers as the package indicated, but it is complex, and we will need to have a conversation with not only the organization to provide the data to the committee regarding the request here, but it goes a little deeper that I can't discuss during this conversation, but we need to have a conversation about the questions that you have about the interview, the number of staff, the wait list, the cost estimate, the reason why the Athena consultant contract position had to be shifted based on legal consultation from the Office of the County Attorney. So I will stop there, but it's a little deeper than just what's indicated in the package. And I thank council staff for noting that and indicating that there's need to be additional information for us to provide to council.
Okay, thank you.
If I may just add, included in the packet, there is information that in FY25, the Treehouse does intend on increasing private funding and donations from 5 to 14%. So while we are still not sure yet, it's still too early to be able to determine what the impact might be of swapping the lines. We will continue to have conversations with the contractor to gauge what that impact might be, but there could be a possibility that that might be offset with some of that funding, but we will continue to monitor it. Thank you.
I think my biggest concern is the population that this nonprofit is being funded to serve, and I don't know how many people are not being served. I don't know how many people work there, and we're being asked to make decisions, and we don't have a lot of information. So I'm just trying to understand. We want to make sure that this population is being taken care of, but we don't have any information. And so, are we making a decision on this?
I don't think there's a fiscal ask in this.
We can bring this.
Yeah, no.
I'm sorry.
Sorry, go ahead, Vivian.
I was going to say, we can bring this back to our follow-up session. We did request some information from the Treehouse, but, I mean, this is what they provided, but we can get a little bit more detailed information for follow-up.
Yeah, I'm going to get in the queue in just a second. We're going to go to Councilmember Lukey, and then I'll make a couple points as well.
Thank you, and thank you for the service data in the packet. It's a good thing to see there was less forensic interviews, because that means we have less of certain things happening, right? And I noted that the medical number went down to the number of individuals who needed medical treatment. So did the mental health, but the family advocate numbers went up by 100. And I was wondering if anyone could speak to that data, and perhaps maybe based on the look back over the prior, and I know we're only FY24 to date, so I don't want to jinx ourselves. I'm going to knock on wood and not jinx ourselves, but there is a higher uptick in the family advocate services that are being provided. And I would guess once we got to the finals, the medical and mental health would probably be in parity with what happened in FY23. Do you have any information about how Treehouse may be allocating or reallocating its resources in order to meet the shifting needs? Anybody?
There's a long silence. I am getting updates real time.
Okay.
We just need to get information, Councilmember Lukey, regarding the metrics and the data from the Treehouse. Council staff has reached out, and we haven't received it yet. So.
Okay. Well, just note that for the future discussion. Thank you.
Yeah, I'll just be quick here. We do need to revisit this. There are some fundamental and important questions that need to be answered. Everybody here and in the community agrees with the priority that this population is and the sensitive nature of this work, and there's a long history with the Treehouse. And we appreciate and respect their work tremendously. We've expanded their footprint, supported their capital investments, and it is of concern, as I'm sure it is to my colleagues in HHS, with one less therapist, and we just need to better understand what that impact would be. So let's revisit this before we get back to full council. All right,
Okay.
let's move on.
So the next item is converting 3 broker positions that were previously grant funded to merit staff for the Office of Eligibility and Support Services. These brokers assisted customers with signing into the computer system, answering questions, triaging customers, directing them to the right place, helping them fill out their applications, etc. So in the end, they were very useful in reducing overall wait time and enhancing overall customer experience. And certainly the numbers for public assistance program has risen exponentially since the pandemic. So in 2020, there was 490 customers signing in at the Silver Spring office, moving to 1,300 in 23, and now almost 1,900 by February of 24. So council staff concurs with the recommendation of the executive. There's a great demand for these services. This would go on, though, the new and enhanced program list.
No questions or comments from colleagues, I think without objection.
Okay. The next item is funding that would be used it would be general funds that would be used to draw down state funding for the summer electronic benefit transfer, summer and winter school break children's food program. Sorry, that's a mouthful. Anyway, these are resources that will help to feed 71,936 children, and it is a good deal.
And it is required, yes? Yes.
The match is required.
Yes, they do.
Yeah, definitely.
Without
Okay.
objection, then?
Okay. The executive is recommending the transfer of a long-term vacant position from OESS to the Office of Labor Relations Support. It's $64,889 and 1 FTE. The executive staff reports that this position was created in fiscal year 13, not funded until 23, and not filled. So there will not be at least a service implication for this transfer.
All right, that was easy. Okay.
The next item is in the admin of Children, Youth, and Family Services. It's the continuation of the Youth Safety Initiative program. Total amount of funding is $779,292. It's an increase of $105,593 from the fiscal year 24 level. That includes a 3% increase for eligible nonprofit service provider contracts. That's going to be taken up by the full council. But in addition, the table on page 8 of your packet shows the changes in contract amounts moving from 24 to 25. There is a larger amount for the 480 Club Sports Ambassadors Program, and DHHS reports that this enhanced funding will support staffing required for adequate data collection, monitoring, and evaluation, and how to operationalize best practices as the program grows. Council staff recommends approval of the $673,699 to continue services that were provided in 24, and then adding the 3% increase and the enhanced amounts to the new enhanced programs list.
Councilmember Sales?
Does the 85,000 have to be added to the new and enhanced program list, or can we ask for it to be considered into the approved budget?
Yeah. Following the rules set forth by the council president, anything that is new in the FY25 operating budget, even if it's annualized, is considered a new program.
Okay.
which I've said it 5 times, I'm going to say it 10 more. When I present HHS's budget, I will make sure, and between now and when we publicly discuss this, make sure my colleagues understand that these are not new programs.
Negotiable, yeah.
They may be technically new programs if you're just looking at the budget, but people have been hired, programs have been initiated, people are being served. It is really important that we keep this going, and I will be making that point.
Okay. And then I just had a quick question about the Florence Crittenden program. Is this the $412,000? Is that what they requested?
No, so the initial amount was for $400,000 to support an expansion to 6 new middle schools. The addition that what you see the amount creeping up is just adjustments that have been done, inflationary adjustments from the past fiscal year. So we're just carrying over the same amounts.
Okay, so that's all they needed was the $412,000?
To support the operations for the of only those 6 new schools, yes.
Oh, okay.
Yes. If we, in the future, if the county is interested in expanding to have their services to support Black girls at the middle school level and have a footprint in more schools to offer that positive youth development, that's a different conversation with the provider.
Yes, because I just remember so many young women from the program testified, and the numbers, the graduation rates were incredible. So I'm just want to make sure that this is enough to support the continued growth of the program. So, okay, thank you.
All right.
The next one is the recommendation to eliminate the Maryland Vietnamese Mutual Association contract for $87,321. This is in the Child and Adolescent School and Community-Based Services Program. Executive staff explains that the contractor's services have shifted from providing tutoring to students and parent engagement to responding to increase in need from seniors. Most of the services provided by the vendor now support, seniors in accessing various benefits and services, including Medicaid, energy assistance, naturalization, SNAP, unemployment, translation, etc. The MVMA's request for funding and contract scope changes is included in your packet at circles 24 to 32. And DHHS had indicated that these services provided by the vendor can be absorbed through other county efforts. They've also connected the contractor with the Office of Grants Management to apply for a SNAP outreach grant, and recommended that the contractor explore potential eligibility for a grant with the Asian American Health Initiative. This is an item that council staff hasn't been able to look at holistically from the perspective of children, youth, and families, and where this contract sits right now. Council staff recommends eliminating it because it does not have to deal with supporting children and parents for school and community-based kinds of issues. The larger question is, are there any other options to support the organization? And at this point in time, I think we're trying to, we would like to bring this back to the HHS committee at the follow-up session.
Yeah, totally agree. Appreciate the testimony from MVMA and the wonderful patrons and participants of the program that they brought, and the orange hats, and they had 2 buses that couldn't make it because of an issue. So the room literally would have been completely full. So they are serving a need. They are doing good work. There is some clarification that needs to be done on exactly which populations they are serving. They have expressed a willingness to clarify and provide information. So I think we'll put a pin on this one too and revisit this in a week or so. When we have even more info. Okay. But I agree with, it doesn't need to live within children, youth, and families until we know more. So, yes.
before we come back again, and knowing and appreciating that the community has identified what it's perceiving its needs are, right? And of course, I know that you all are trying to identify what, on the executive branch side, what those how those needs could be served by things that are already happening, or ways to fund them with other grants, et cetera. But this was a multi-year contract, is that correct? For the services that were for the tutoring and parent engagement? Okay. Yes.
Hi, good afternoon. Monica Martin, Administrator of Child and Adolescent School and Community-Based Services. Yeah, this is a contract that's been in our base budget since fiscal year 2011, and it's been renewed annually with the county exec's recommendations.
Would it be possible for us to get a copy of the contract so that we could actually review it and see what the scope of services were?
Absolutely.
Because that's important, and if those are not what's needed presently, but they've identified something else, then the question becomes, what does the executive branch believe it should be contracting for with this entity in that community, right? So that would be very helpful so we can see what the scope of the contract was. Thank you.
I believe it may have been included in Maryland Vietnamese Mutual Association's letter submitted to the county executive's office after the recommendation. I think it was one of the attachments.
Okay.
As well as the only amendment that changed any of the scope of their work since the establishment of that master contract. But just to clarify, the scope of the contract as it exists today, it does include services to seniors. The focal point had been the tutoring of student pieces, and it's about where things have shifted over time, and again, what the community really needs and how to support that.
Right. Yeah. And it, so I guess my next piece was going to be, in terms of annually monitoring what services are being delivered and working with the group. I'm assuming that has been done over time, and that everybody is understanding that there's more of a need in one way than there was in another way under the prior contract. Okay. Thank you.
Correct. And at the time of this recommendation, we didn't have the updated report that's been provided to you since.
Okay.
So we had no evidence of some of the youth-focused programming occurring for now a second fiscal year.
Okay. Thank you.
Thank you.
Okay. The next item is multi-program adjustments. Each program has this that covers compensation changes, benefit changes, et cetera, that affect multiple programs. So the table on page 9 of your packet shows for each program the adjustment and the FTEs. You'll note there's a significant decrease in admin of children, youth, and families, but that is related to the newcomers program being shifted out of CYF. And there are FTE changes for child welfare services, early childhood services, and Office of Eligibility and Support Services, and they result from minor allocation changes to grant funds or to meet operational needs. The council staff recommends approval of those. For the Positive Youth Development Program, the only recommended adjustment is a multi-program adjustment, and there is budget and service data for the program at Circle 15 of your packet.
Great. Okay. All right. No objections?
Okay. The last thing in the packet is just a vacancy update. The service area has 119 vacancies, and of those, 45 positions have been vacant over 1 year. The total vacancies, of the total vacancies, 46 are in child welfare services and 37 are in Office OESS. These are two programs that have historically experienced high numbers of vacancies and staff turnover. The vacancies in children, youth, and families include 39 social workers and 28 government assistance eligibility specialists. Post-pandemic, these vacancy numbers continue to be higher than they were pre-pandemic. So in fiscal year 19, child welfare services carried 21 social worker vacancies, and OESS carried 19 eligibility support specialist vacancies. This is not, again, a surprise to us now because of the difficulty in attracting these kinds of helping positions. Excuse me. Council staff does note that there is a downward trend in the number of income support specialist vacancies. There were 34 at this time last year. Now there are, I think, 28. But the number of social worker vacancies is comparable to this time last year.
Councilmember Sales?
Yeah, where and how are we seeing the effects of these vacancies in Children, Youth, and Family Services?
Come on, Dr. Mensah. As Dr. Mensah joins our great social services officer, he could elaborate a little bit more on what we're seeing on the social services end.
Yeah, Oscar Mensah, Social Services Officer for Montgomery County. It's great to report that we've seen a positive trajectory in terms of how we are recruiting our staffing. Just recently with a partnership with our Office of Human Resource and our wonderful HHS Human Resource, I will say that we are in the point of recruiting 20 new candidates in the Office of Eligibility and Support Services. And we also, when you go to child welfare, we do have great partnership with universities at Shady Grove and building on a student intern fellowship program where we're able to give students stipend and they're able to give back to our community and be able to serve in our child welfare program for 2 years. So the strategies that we have in child welfare and Office of Eligibility and Support Services are really trending in the positive. And to come here next year is going to interest all of you to see that we're going to be trending positively and even more. And I'm appreciative of where we are right now and then where I see ourselves going.
And if I may, to elaborate on some of the strategies that Dr. Mensah has indicated, and also to explicitly respond to your question, Councilmember Sales, we've been very adamant. This has been while it's been challenging, right, it's been a wonderful exercise on innovation for us as public servants because we don't want it to impact services. We have not wanted to see these staffing issues impact our service delivery. So it has stretched us to think of creative and innovative ways to think outside of the box on how we can meet those gaps, particularly in child welfare. We've been converting, really assessing where do we really need a clinical social worker versus what are some of the lines that we can convert in the bodies of work that don't necessarily need to be done by a licensed clinician so that it could open up the pool for us to hire. And thinking of scholarships, creating pipelines and partnerships with the universities to create a direct pipeline to work. So it by no means does it resolve the issue, but it really is stretching us so that we can ensure that there are no impacts to our services.
And so these social workers are the ones tasked with tracking and monitoring in-home visits with foster care. Is that correct?
That's correct, yeah.
Okay. And so over a year, we've been down 39 social workers, 28 eligibility specialists. So what's the current status of children that are currently in foster homes? And what's the current caseload for each social worker?
Yeah, during the peak time, what we did is we partnered with our staffing contract, Athena Services, to support us with some social workers, and I will say that was very successful. They were able to kind of use it to, they were able to provide us with some staffing to fill some of the gaps, and even though we're showing that there is a vacant rate, we did have some staffing support somewhere from Athena in order to be able to provide services to our children and our families. When it comes to the CPS staff, we did ensure that some supervisors were helping with carrying some cases, and then to be able to kind of give some relief to the staff. Case carrying averages, it depends on which section of the work that you are in, whether you're in your home or whether you're in in CPS services. I do not have the number handy, but if we need the average caseload, definitely I'll be able to provide you with some feedback on that.
Just so you know, those for February 23 and February 24, it's actually in your packet at Circle 11. It shows that out of the average caseloads for out-of-home, in-home family preservation, and CPS. It is also important to note that these vacancies are a point-in-time number, so it's not, they fluctuate during the year.
And if I may jump in quickly also, we do have like 209 FTEs, and then out of the 209 FTEs, it's not like we are going, we don't have the staff like I mentioned. We are using the broker contract to support us, and then some of them have also kind of transformed into merit staff, which has become really a good pipeline for us to be able to get staffing to support our staff as well.
So is that 14 children per, I'm not sure what this chart is saying. It says the monthly average caseload, is that total, is the 14, 13, and the 6, or is it just the 14?
Yeah, so
is it cumulative or?
Yeah, it's point in time, right? And for example, if I'm carrying 14 cases right now, at some point you have to close cases, right? Mm-hmm. And then you're going to have new cases, and then that's the average that a CPS worker is carrying, 14.3. Yeah.
So is it saying, so a CPS worker only has 14 and in-home family preservation only has 6?
Yes.
Oh, okay.
Yeah,
okay.
And you cannot match. You cannot really match them or compare them because of the intensity of work that each one does. Mm-hmm. And then if you bring new cases in at some point, by 60 days you have to close it, and then you have to disposition it, whether it's in home or out of home.
Okay.
Yeah.
And you'll get back to us with the number of children that are currently in foster homes.
Yes.
Okay.
Mm-hmm.
Thank you.
Councilmember Lukey.
Very quickly, and good to see you, Oscar, as always.
Great to see you.
Quick question. Have we changed any of our hiring processes to account for allowing for conditionally certified social workers?
Sure, I'll jump in. I'll take this. So yes, Councilmember
God bless you.
Lukey. Yes, absolutely. So we just hired a human capital manager, and she's looking at all of the various nuances. That is something that we will present to her. I met with her this morning.
Oh, okay.
Not only talk about workforce development, but really focusing on the recurrent theme of reducing our vacancy list across the board. As I indicated last week, we're all competing for the same social workers, clinicians, et cetera. But there's a better way to do it. There's a different way to do it, and we are unpacking how to do that now. So the short answer is yes, we are looking at alternative strategies. I know Mr. Hodge, who's sitting to my right, your left, did this with our school health services.
Yes.
And so we're looking at those innovative strategies to reduce our vacancies. So it's across HHS. I know we have a conversation with CYF now, and Ms. Trevance and Dr. Mensah hear it all the time from me. But I'm sharing this with you. We are working on it, and we will reduce, and we prioritized it. So yes, we are looking at those alternative strategies. There are credentials, and looking at whether or not it's a licensed clinical social worker, whether or not it can be a student, whether or not it's a university-based or part of an internship. So all of those are being put into the process to be considered.
And I know that was a more recent change. It's not this year, but it was maybe last year or the year before, but maybe last year. Somebody, it's all in there somewhere. But, and so again, to the extent that we're competing against everyone else for the social workers, especially since it allows for that mentoring because of the pairing of the person who's attained the degree and is awaiting their certification from their exam. Like lawyers, when you take the bar exam, I've got a law degree, I took the bar exam, I got to wait till my results come. Now at least they can log on. Back then I had to wait for mail. But, that helps, and that again fosters that pipeline, particularly if you are getting people in while they're still in school, and then you're allowing them to earn income at a different level as they've obtained their degree before they get their certification. That would help. So
just to add, and I said some of these things last week, which may be why it's fresh in your mind. So for the social workers, one of the things that we have to do, the way we set up our classifications for a lot of these positions, when they were created 5 years ago, 10 years ago, 15 years ago, they were set up as social worker 3s. And that requires a master's degree with certification before you can even apply for that position.
Right.
That's the minimum criteria. And so what we're having to do now to kind of try to backfill some of those other positions is change that classification. So we're going to we have to abolish the social worker 3 and do a social worker 2 position, which lowers the minimum qualifications for that position. So it allows us to provide conditional offers to those who just graduated, who are awaiting their certification, but get them in the door. We also are currently funding scholarships for 6 master's students at ESG in social work who are doing their internships at the same time in child welfare, and with an expectation that they will work for child welfare, be hired automatically and work for child welfare for 2 years after that. So there's some pipelining that we're doing as well, but a lot of the things we have to do requires us now to change our classifications in order to lower the qualifications that we have.
Thank you. I appreciate that, and y'all just made me very happy. So thank you.
And just to respond to Councilmember Sales' question, on Circle 3 of your packet is the performance measures for child welfare services, and it includes number of children served in foster care by fiscal year. So if that helps, there has been an increase.
Oh, well, I was looking on page 4 of the expenditure review. I don't know if that was the same one that you're talking about.
Page 4. You mean Circle 4 or?
Page 4 of the packet. It said expenditure review to community service aids to child welfare services for service delivery and transportation.
Right.
In the second paragraph, it just said, that as of January, 333 children were placed in out-of-home care. And was that with regards to the social workers
it's
for foster care?
It's not necessarily, I don't think, the total number of kids that are being served in foster care.
Oh, that's just for this fiscal year?
So.
Oh, okay. I thought that was pretty low. So I'll wait for the actual numbers from Mr. Mensah. Okay. I just had a quick question since Councilmember Ludke brought up the incentives. When we noticed the shortages with public safety officials, the county executive recommended a $10,000 sign-on bonus. And so, as we're looking at scholarship opportunities, I know that it's continuing to rise, the amount of social worker vacancies. And so if we have any other creative ideas that we can think of, now's the time to let us know. Thank you.
All right. I think that's it for this afternoon's session. Thank you all very much. We will continue at a very soon later date. All right. With that, we are adjourned.
Yes, tomorrow morning.